Good morning. We're going to go ahead and get started. So if I could have commissioners come to their seats. Thank you. Perfect. Thank you, everyone. Good morning, everyone, and welcome to this Mental Health Services Oversight and Accountability Commission meeting. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to apologize this morning for being a little delayed. We had some technical issues, so please accept our apology. We are going to get back on track. I want to thank you for attending today's meeting. The Commission's strategic plan for 2020 through 2023 is committed to advancing the Commission's vision of well-being for all Californians. Cody, can you please bring up the strategic goals slide? Thank you, Cody. Now we will take roll and establish a quorum. Jeff, can you please take the roll?
Commissioner Bontrager. Commissioner Brown. Here. Commissioner Bunch.
Present.
Commissioner Carrillo. Commissioner Carnevale. Here. Commissioner Chambers. Commissioner Chen. Commissioner Cortese. Commissioner Danovich. Here. Commissioner Gordon.
Here. Commissioner Gordon is here.
It appears that we're having trouble hearing Commissioner Gordon, who appears to be online.
Yeah, here I am.
He's acknowledged his presence. Commissioner Mitchell. Commissioner Robinson. Commissioner Rolette. Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal Weiss.
Here.
Madam Chair, we have a quorum.
Thank you, Jeff. We are now moving to agenda item 2, announcements and updates. But before we do that, I would like to welcome Dr. Curley Bonds to our meeting today. Dr. Bonds would like to take a moment to welcome the Commission to Los Angeles and to tell us about some of the great work being done here around the county. Dr. Bonds is the Chief Medical Officer at the Los Angeles County Department of Mental Health. Dr. Bonds, thank you for being with us today.
Welcome to the commissioners. Welcome to the great county of Los Angeles. Our department has been growing and innovating in ways that I won't be able to fully capture in the few minutes that I'm allotted. But I will spend some time to highlight a few key projects that may be of interest. And I also want to give a welcome on behalf of our director, Dr. Lisa Wong, who couldn't be here, and our deputy who's overseeing our efforts, Kayleen Gilbert, who's in the audience. So first I'm going to talk about Hollywood 2.0. Some of you know that a few years ago, a group of dedicated Angelenos went to Trieste, Italy, and came back with some innovative ideas about how we can really engage more in whole person care. And that was a project that resulted in a 5-year innovations project for $116 million to radically transform services in the Hollywood catchment area. We spent much of the last year gathering community input. I don't think there was any voice that we didn't hear from. This included stakeholder engagement meetings sponsored by our intermediary, Hollywood Forward. These were a series of convenings to hear from people on the ground, what type of services does the Hollywood community need? We followed their lead to build services that match the needs of the community, and it has now come to life in the form of what we call the Hollywood Cooperative, which has 40 staff members with a target of 54. And one of our challenges, as you know, is recruiting mental health staff. This innovative project has helped us to do that. Since January of 2023, we've received over 100 referrals, and we now have about 73 clients who are actively receiving services. We've contracted with Fountain House from New York to launch what will be the first clubhouse in Southern California. and the inaugural members are already meeting regularly to talk about how they'll engage in the social practitionership, and they'll finalize a lease for space, at least temporary space, later this year. We've also partnered with New Dawn to support a 94-bed boarding care facility, which services are provided by our field-based teams. Earlier this month, we held the ribbon cutting for a 56-bed interim housing site located at the Mark Twain Hotel. The initial feedback that we've received from community members, including peers, is that the response times for getting people services is much faster than it was before we implemented. We anticipate that more good news will follow. Another area of interest for this group is substance use disorders. Here at LAC-DMH, we have always been able to provide care for those with co-occurring disorders. We actually have an associate medical director, Dr. Jeremy Martinez, who oversees these efforts. He's addiction trained. Under his leadership, we now have naloxone in all of our clinics, and we have a distribution program. All full-service partnership and home team staff have been trained to distribute naloxone in the field. We have also started co-occurring integrate recovery groups at 6 of our clinics with the plan to expand to 16 next year. We've also had planning discussions with our colleagues at SAPC to discuss the future of when our agencies will be working more collaboratively and sharing administrative resources. As you can see, we have a lot of successful programs that I'm very happy and fortunate to oversee with our staff of over 6,500. And on behalf of my team and Dr. Wong, a warm welcome to Los Angeles. I hope that you have an informative and educational visit here.
Thank you, Dr. Bonds. I appreciate you coming to welcome us this morning. I appreciate your time. Thank you, sir. The August 24th and September 5th Commission meeting recordings are now available on our website. The next Commission meeting will take place on October 26th in San Francisco. The meeting will feature a panel presentation on the Commission's impact of firearm violence project, and we will also receive a briefing from staff on the Governor's MHSA modernization proposal. The day before the Commission meeting, on Wednesday the 25th, there will be a site visit for Commissioners to hear about advances in neuroscience and brain research from researchers and partners from UCSF. Commissioners will hear how neuroscience can drive innovative assessment and treatment approaches within a prevention and early intervention framework, which in turn can drive policymaking best practices. Staff will be sending out more information in the coming days. The CFLC will be meeting on Wednesday, October 18th from 1 to 3 p.m. The committee will hear an update on peer certification process and will discuss potential impacts of the behavioral health modernization on county programs. The CLCC will be meeting on Tuesday, October 24th from 4 to 5:30, and an agenda for both committee meetings will be posted 10 days before the meeting. The 2023 legislative session ended on September 14th. 2 out of the 4 bills the Commission supported are waiting to be signed over or vetoed by the Governor. Senate Bill 509 by Senator Portantino, a bill related to behavioral health training in schools, and Senate Bill 10 by Senator and Commissioner Cortese, a bill related to opioid overdose prevention in schools. The other 2 bills, Assembly Bill 1282 by Assemblymember Lowenthal, related to the impact of social media and AI on youth mental health, and Assembly Bill 599 by Assemblymember Ward, related to a public health approach to suspensions and expulsions in schools, unfortunately did not make it to the Governor's desk. But it is our understanding that these 2 efforts will resume during next year's legislative session. Lastly, Senate Bill 326 by Senator Eggman, the Governor's modernization proposal, which the Commission voted to support with concerns at our last meeting, is also on the Governor's desk awaiting action. The Governor has till October 14th to sign or veto legislation, as mentioned. Last month, the Boston Consulting Group presented an update on the Commission's strategic plan process. The goal of Anna's presentation was to help the Commission and the public better understand the extent, breadth, and value of the community engagement aspect of the process so far, and discuss the criteria to assess the adequacy and quality of the engagement process and the draft framework for the Commission's strategic plan. Deputy Director Norma Pate presented opportunities to gather more feedback on the themes in the draft framework. The subsequent public outreach activities would focus on specific audiences to get feedback on the draft plan, including the proposed goals and objectives and the questions regarding priority setting. Commission staff will report what was heard and how it was incorporated or considered in the developing plan and present a revised plan to the Commission at the November 16th Commission meeting. The goal is to adopt the final version of the strategic plan and framework in January of 2024. We have received many positive comments via our website and are still seeking feedback from the public. If you have not done so, please fill out the form on our website to provide written feedback. We will be holding another listening session in October and will send out notification of the date soon. We want to thank the public for participating in this process. Next, we will hear an update on the impacts of Firearm Violence Initiative. I would like to invite Commissioner Bunch to make her update.
Thank you, Chair. I'd like to start by thanking Courtney Ackerman and the other OAC staff for the amazing job that they've done with this project. As the Impacts of Firearm Violence project moves into its final phase, commissioners and staff are working hard to solidify the insights gleaned from our engagements and make meaningful connections to build collaborative, community-defined solutions. One of our main findings is that mental health and firearm violence do intersect in many ways, but rarely with a diagnosis of a serious mental illness. Rather, we've learned that people reach for firearms as a last resort to solve their problems. From our engagements with multiple affected populations, including youth impacted by firearm violence, dedicated youth education specialists using firearms as tools for positive youth development, experts in trauma prevention and mitigation, violence intervention staff, and more, we know that there are many promising strategies that evidence-based solutions that go upstream to prevent firearm violence and its associated negative outcomes long before concerns over firearm access arise. A few of these promising approaches will be highlighted in our panel next month, along with some of the barriers, gaps, and key opportunities for firearm violence prevention and healing. We look forward to continuing the discussion in October.
Thank you, Commissioner Bunch. I would now like to invite Melissa Martin-Mullard, Chief of Research and Evaluation, to make some announcements. So Melissa's not in the room. Everybody's looking at me. She's online. So I'm hoping that Melissa's going to jump on.
Okay, sorry, I couldn't unmute for a moment.
No
Thank you
problem.
for your patience. So I'm going to provide an update on the Mental Health Student Services Act evaluation, as well as our initiative on full service partnerships. I'm going to start with the Mental Health Student Services Act, which, as you know, provides grants to strengthen partnerships between county mental health departments and local education agencies to support school-based mental health services to students and their families. Grantees have quite a bit of latitude in how they use their funds, as long as the goals are to prevent mental health challenges from becoming severe and disabling, improve access to mental health services, provide outreach to families and others to promote recognition of early signs of potentially severe and disabling mental health challenges, reduce stigma, and prevent the 7 negative outcomes outlined in the MHSA, including suicide, school failure, and incarceration. The Commission has contracted with WestEd as our evaluation partner for the evaluation planning phase. This phase is essential because we need to understand how grantees implemented their local programs, how the MHSSA activities fit within the larger school mental health landscape at the local level, and hear from grantees, parents, students, and other community partners what the metrics and outcomes they feel are most important to highlight and evaluate. To accomplish these objectives during our planning phase, WestEd has begun a series of listening sessions with grantees, after which they will convene a series of meetings with parents, students, and other community partners to facilitate conversations to inform the evaluation and learning agenda. Alongside these engagements, Commission staff, under the leadership of Dr. Kai LeMaison, who was recently promoted into the supervisor role for this project, is working with grantees on data submissions and will be drafting the second report to the legislature on student outcomes in March 2024. We see these reports to the legislature as opportunities to share out the progress of the act, to lift up promising and best practices that grantees are implementing, and to shine a light on system-wide barriers and challenges. Finally, we are tying the Universal Screening in School project to our MHSSA efforts and held a kickoff meeting last Friday during the MHSSA work group meeting, where we heard from grantees implementing universal screening as one of their strategies and heard about the work that the Children and Youth Behavioral Health Initiative has already completed in this area. Due to an unfortunate technical difficulty at the end of the meeting, we will be scheduling a follow-up in October to wrap up the discussion and hear work group member and public comment. Next, I'm going to provide a brief update on our full service partnership work. The Commission was directed by SB 465 to provide biennial reports to the legislature on how well FSPs are working to meet the needs of those with severe mental health challenges to reduce hospitalization, criminal justice involvement, and homelessness. Back in April of this year, we toured 2 FSP sites in Sacramento County and then heard from a panel during the Commission meeting that included a person with lived experience, a provider, and one of the original creators of the FSP model. Since then, we have hired our staff lead for this project, Dr. Callie Clark, and contracted with 2 outside agencies to support various streams of this effort. I'll briefly describe the work that our external partners are doing first. Third Sector is in the process of gathering information from FSP providers, county behavioral health, consumers, families, and other partners to build off the work that they did with our multi-county collaborative FSP project. This work is to identify areas for capacity building, data quality improvement, and metrics of success. We've also contracted with Healthy Brains Global Initiative to develop a model for performance-based financing for FSPs. We will hear a report out during November's Commission meeting on this work. Commission staff will also be convening public meetings to facilitate discussion on how to strengthen our system to better serve clients and address the needs of those still suffering, living on the streets, or continuing to cycle through the criminal justice system and hospitals. These broad goals are, of course, in alignment with the governor's modernization plan. The Commission is grateful for SB 465 and the mandate that directs the Commission to evaluate FSPs and identify best practices and opportunities for technical assistance and capacity building that is in support of the governor's vision to better serve our most vulnerable Californians. Thank you so much for the opportunity to provide these updates.
Thank you, Melissa. We will now hear updates on new staff joining the Commission. I'd like to welcome Andrea Anderson, Chief of Communications.
Thank you, Madam Chair. You guys hear me okay?
We hear you fine, thank you.
Awesome, thanks. Yes, we are super excited to welcome 2 new staff to the communications team. I want to introduce Justin Marshall, who's actually in the audience with you guys there today. Justin is a 17-year media professional with a passion for storytelling across multiple mediums, including but not limited to social media, broadcast, written, and various other digital platforms. Justin has on-air experience in talk radio and was responsible for external communications with local and national press contacts as he supported communications for the Sacramento Kings, the Oakland Athletics, and the San Francisco 49ers. So hopefully we have some fans out there that can relate to Justin, and we're super excited to have all of his background joining us on the Commission on the communications team. We're also going to be welcoming, or we have welcomed, Jorgen Gilliksken. Jorgen is joining us virtually today. And Jorgen is a professional written and visual storyteller with 7 years of experience in nonprofit brand building, as well as an award-winning photojournalist with recognition from the California Newspapers Publishers Association, the National Press Photographers Association, and the Eddie Adams Workshop. Some of Jorgen's favorite projects in his last role at the Land Trust of Napa County included designing consulting, managing, and expanding a new website for the nonprofit, telling conservation stories with words, photos, and video, and increasing their social media profile. So we're super excited to have both of these gentlemen joining us on the communications team, and we'll be working with Sarah as soon as she's back from her leave in support of obviously the new strategic plan, as well as all the other communications functions of the commission. So I'm super excited to welcome them both aboard.
Thank you, Andrea. Welcome. Happy to have new staff on board, such a talented crew. We just keep growing, so welcome. Happy again to have you here. And now it is my honor to have Ashley Mills join us today, so we may present her with a resolution. Ashley's contributions to the commission are numerous and meaningful, and I would like to highlight just some of her key contributions. First, Ashley spent 10 years elevating policy research. Yes, please, sorry, I should have said that. Come on up, Ashley. Policy research projects that guided policy and practice recommendations, which led to changes in state law, as well as public understanding of various issues. Ashley led the Commission's work to promote criminal justice diversion, authoring a report that shaped California's investment in decriminalizing mental illness, supporting diversion, reducing costs, and improving individual and population outcomes. Ashley also led the Commission's work on California's strategic plan for suicide prevention, Striving for Zero, California's strategic plan for suicide prevention 2020 through 2025. This work resulted in the establishment of California's Office of Suicide Prevention and the largest state-level investment in suicide prevention in California's history. I had the pleasure of working closely with Ashley on the Commission's prevention and early intervention efforts, which culminated in the release of Well and Thriving, Advancing Prevention and Early Intervention in Mental Health. Finally, Ashley launched the Commission's work on the impacts of firearm violence, recognizing the intersection between access to lethal means, suicide risk, trauma, and firearm violence. All of this work is just a small reflection of Ashley's leadership, which was grounded in persistence, intellect, compassion, and warmth. She not only supported her team, but was a trusted thought partner to many of us on the Commission and to our outside key partners outside of the Commission. Ashley has moved on to a deputy director role within California's Department of Public Health, where she continues her service to the state and to the public. We were fortunate to have her for a decade, and the Department of Public Health is lucky to have her now. Ashley, thank you for your commitment to mental health and well-being for all Californians. Your work has truly made a difference for the lives of millions across our state. You are an inspiration to us all. The work we have done together, you're not only an incredible staff member, you've become my friend. And so I thank you for everything you have done. I'm going to invite Commissioner Brown. Before we present Ashley with her recognition, I want to invite you to say a few words about her contributions to the Commission, please.
Thank you, Chair Madrigal-Weiss. And it's generous of me to say thank you because you just took about half of what I had prepared to say about Ashley. But in addition to the resume, which is very impressive, the foundation that she had as a research analyst with both the California Department of Justice and the California Governor's Office of Gang and Youth Policy Violence, youth violence policy before she came to the MHSOAC. Ashley has matriculated through that series of projects that you just mentioned. She has shepherded them in a very thoughtful, a very meaningful way, and she has really shown me and the rest of this commission that she really has the right stuff. She is, I think, the epitome of a researcher, somebody who is bright, who is caring, who is gifted in not only research but writing about that research. She's passionate about finding ways that we in California can do a better job of helping people who are in dire need in a variety of different forms. But in addition to all of that, she's witty, she's just fun to be around. we got to travel across the country and look at a lot of different programs, and it was always just a pleasure. She always lifted me and the others up that were with her as we were visiting these different sites across the nation that had programs that were excellent, and many of which that we've actually recommended and emulated. And in the report, the Together We Can report that she was the senior researcher on. And whether it was in that role or whether it was in the role of a research supervisor, she always was conscientious. She's somebody who I find is in it for the long haul. She recognizes the hurdles, the ups and the downs in this business. And she's always driven to excellence. She's a class act. The Department of Public Health's gain is our loss. But I know that she's going to continue to serve the state of California in an exemplary manner, and her future in this line of work, I think, is limitless. So, Ashley, it's just been a delight to have you as a colleague and as a friend. And all of us, I think I speak for all of us on the commission, we wish you, we know that you're going to do well, but we wish you exceedingly well as you go get a seasoned approach to this new role that you're in. So, congratulations.
Commissioner Brown, will you join me as we give her resolution? Please. And I would like to invite any commissioners or staff, if you'd like to share some words. And then Ashley, please, we'd love to hear from you as well. Sure, Commissioner Bunch and Commissioner Danovich.
I just wanted to thank Ashley for all of her work. We got to work together with the impacts of firearm violence, and it was amazing. It was particularly in the beginning, it was a hard subject, and I appreciated your feedback and support, and I miss you, but I'm so happy for you, and I know you're going to continue to do amazing things. Thank you.
And I would just echo all the comments and adulation. The only thing I would add is just the caliber and the quality of the reports that you led and helped to write was just outstanding. And I think really set the bar on what we would hope to continue to achieve in our work products in the commission. So thank you for doing that, and it was a pleasure working with you at all levels.
Yeah, thank you, Ashley. Just, for me personally, you've just been a profound partner in helping to shape the work of the commission, and it's really exciting to have you at the Department of Public Health. And we know we have a partner, just an incredibly visionary, strong partner who can work with us to really drive the kind of transformational change through a prevention lens that we're so excited about as we move forward with the governor's reform proposal around behavioral health. So everything that the commission has been able to do over the last 10 plus years has had your fingerprint on it. And so we certainly recognize that and hope you recognize that as well. Thank you for everything that you've been able to do.
Thank you so much. I said I wasn't going to cry, and I'm fighting. But that's okay, because tears of just incredible joy and gratitude to this commission. In the pursuit of transformational change of our system, I have experienced my own transformational change, and that was largely grounded in the work that I was able to do to support this commission. I've been thinking, when I heard about this resolution, I don't know if it's imposter syndrome. Maybe we all kind of think about it like, how did I get here? How how was I able to be in this position where I'm able to do all of the great work with all of you and then continue that work in my new role? And it started with Commissioner Brown, who saw people who were coming into his jail who could have better received services outside the criminal justice system, and it was an inappropriate place for people with mental health challenges. And he had enough, and he brought that issue to the commission, and the commission said, yes, we need to lean into this opportunity, we need to work together, we need to reach across our partnerships, and we need to create an agenda for how we're really going to reduce the number of people with behavioral health challenges in our criminal justice system. And Toby came to me and he said, well, you have a background in criminal justice. And I said, yes, I do. And he said, well, what do you think about being staff to this subcommittee? I think that you would be a really great fit. And I said, I don't know what that means, but I want to be a part of Sheriff Brown's vision. So count me in. And with that simple yes, it led to an incredible experience in which I was able to create a suicide prevention plan for the state of California, which young teenage me who had thoughts of suicide, really, I was like, wow, I can make a difference in this space. Whatever I did, however many times I said yes, I did it right, and it's led me to this point. And so I was able to be a part of that, and it was because of the leadership of Commissioner Wooten and other commissioners where I was able to be supported in that work, and I was able to put forward a suicide prevention plan that led to the creation of an Office of Suicide Prevention within our Department of Public Health. And now I oversee that Office of Suicide Prevention within the Department of Public Health. It's a fairy tale story, and I often have to step back and really recognize all of the efforts and the inspiration from this commission and the guidance and the bold leadership. And it gives me the courage to step into these spaces and to speak from my heart and to trust myself and my authentic self and recognize that there are solutions. There are solutions when we work together. And so I'm really excited to bring that legacy into my current role. I wanted to share, I know we're kind of running out of time, but I wanted to share where I am in the department as an invitation to explore opportunities for where we can create some additional partnership. I oversee our Injury and Violence Prevention branch, which includes our Office of Suicide Prevention. I also oversee our Substance and Addiction Prevention branch, which includes our Office of Problem Gambling. So I see you have substance use disorder treatment on your agenda. We welcome the invitation to come forward to this commission and lift up some public health approaches for prevention and substance use. And then I also oversee our tobacco prevention program as well, which continues to be a huge source of inspiration for me because that has been such a successful program for the last decade. Countless lives have been saved, countless dollars have been saved, and it's because of a public health approach to addressing a really challenging issue. So I really welcome any opportunities to continue to work with this commission. Please consider me a partner. Our strength is in our partnerships. Our strength will always be in our partnerships. And I'm just so grateful for this opportunity. Thank you so much.
Thank you, Ashley. This is no way goodbye. It's see you later, and partnerships, absolutely, see those happening. So thank you. Thank you. So I would like to once again welcome everyone again to today's meeting. The plan is to end at around 3 p.m. We're going to clarify the... So we just need to make a correction on quorum. So at this time, I'm going to hand it back over to Jeff, please.
Thank you, Madam Chair. I'd just like the record to reflect that I erred earlier when I announced that we had a quorum. We did not, in fact, have a quorum at that time. We were a little short. However, we do have a quorum at this time, and I'd like the record to reflect that Commissioners Robinson and Chambers have joined the meeting.
Thank you, Jeff. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for Agenda Item 3, General Public Comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take the comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen.
Thank you, Amariani. Would you please open the line for general public comment?
Yes, we currently have 3 public comments. First, we have Richard. Your line is open.
Good morning, everyone. Richard Gallo from Santa Cruz, California, a person with lived experience, a peer support specialist who completed the training. I just wanted to inform the commissioner of my disappointment in your last meeting in voting for SB 326. Obviously, you are okay with counties losing funding with the way the state is going with the Modernization Act and the reduction of buckets to use for other purposes. The Mental Health Services Act funding was not meant for care court or any other treatment programs and services. Obviously, this is going the way it is as a Proposition 1. What we need to do as the voters, the peer community, is to educate the community to vote this bill down. It is a political power grab by our state elected officials who did not include peer workers in any of the state agencies. I would hope that the Oversight Commission will include peer workers within the agency to help with their goals and achieve programs and services that benefit the mental health community throughout California. Thank you.
Thank you, Richard.
Next, we have Stacy. Your line is open.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. First, I would make a request that the commissioners could speak up, because those of us online can barely hear you. I know I'm not alone because we've been texting each other. So if you could turn up the volume. Second, I would like to support the comments of Richard Gallo. But third, I would like to cordially invite the commissioners, and I hope you received my invitation but hopefully you saw it before I sent it to you yesterday or the day before. The California Reducing Disparities Project is having a very, very special event that I know you would enjoy. We are having meetings all over the state. We have had a meeting already in both Chico and Oakland, and I was disappointed I did not see anyone from the commission staff or the commissioners at either of those, but there will be a meeting in Fresno and then Los Angeles and also Riverside. And these meetings are extremely important because they will be going over the results of the evaluation of the California Reducing Disparities Project. So if any of you are interested at all in CDEPs or community defined evidence practices, I know you would enjoy hearing about this evaluation. The one in Los Angeles will be held October 24th. That might be the most convenient. But again, there will be meetings in both Riverside and also Fresno. The study was done by the Psychology Applied Research Center of Loyola Marymount University. So I really believe that it is vital that someone from the commission view this. Or, of course, if you would like, I know that we could arrange to have the presentation to the entire commission because it is so important. The second part of the meeting will be to gather public input on phase 3 of the California Reducing Disparities Project. And we would be interested, very interested in what the commission has to say about phase 3. So I hope you can join us at these meetings. They are really fun and you would meet a lot of very exciting and knowledgeable people. Thank you so much.
Thank you, Stacy. Thank you for letting us know that we are not being heard, so we will make sure that the volume's up. We did get the email, and of course, if commissioners are able to make it, but I will ensure that staff attends at least one of those meetings. So thank you for that information. Mariani?
And now we have our last public comment, the phone number ending in 837. Your line is open. The phone number ending
Yes,
in...
this is Mark Carnett. This is Mark Carnett. And I would like to support the comments that Richard made. They are exactly as a lot of people feel. You don't take money out of one pot and put it in another. But that's what that bill would do. That's Senate Bill C-26. We don't want that to pass. It is on the governor's desk now. Don't let him do that. So that's my comment.
Thank you, Mark.
And that was our last public comment.
Thank you, Mariani. The commission will now move on to agenda item 4 and consider approval of the minutes from the August 24th and September 5th commission meetings. At this time, I would like to invite commissioners to offer comments or ask questions. Seeing none in the room and
none online.
None online either. Then I would ask that members of the public may request to make a public comment on agenda item 4 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Please indicate which set of minutes you are referencing when you make your comments. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Mariani?
It looks like we have one public comment from Richard. Richard, go ahead.
I reviewed the minutes and I'm not sure, but I thought I participated and provide comments on that, yet I don't see it anywhere on the minutes of my public comments being made. So I don't know if it needs to be double checked or what. Thank you.
Richard, to which month were you referring to, September or August? Sorry, there you go.
Richard, we will have staff look into those. Thank you, Richard.
And that was our last public comment.
Thank you, Amariani. Now that public comment has closed, I would entertain a motion for the approval of the August 24th commission meeting minutes. Commissioners.
So moved.
Thank you, Commissioner Brown. Do I have a second?
I'll second.
Thank you, Commissioner Bunch. We have a motion and a second to approve the August meeting minutes. Seeing that we had no questions or comments the first time, I would ask then, Jeff, if you would please take roll.
Commissioner Bontrager, Commissioner Brown,
Actually, I jumped the gun there. I was not present in August, so I'll abstain from this vote.
Commissioner Bunch,
Approve.
Commissioner Carnavale,
Abstain.
Commissioner Carrillo, Commissioner Chambers,
Approve.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich,
Abstain.
Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Robinson,
I apologize. I'm having problems hearing. Can you restate the motion?
approve the August 24th, 2023 meeting minutes.
Approved.
Commissioner Rolette, Commissioner Tamplin, Vice Chair Alvarez, Chair Madrigal Weiss.
Approve.
The motion passes.
Thank you, Jeff. I would ask for a motion to accept the September meeting minutes.
So moved.
Thank you, Commissioner Brown. Do I have a second?
I'll second.
Thank you, Commissioner Bunch. I would ask then, Jeff, same. We had no questions or comments. If you would take the roll, please.
Commissioner Bontrager, Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Carnavale,
Here.
I'm sorry, Commissioner Carnavale?
Yes, aye.
Thank you. Commissioner Carrillo, Commissioner Chambers, Commissioner Chen, Commissioner Cortese, Commissioner Danovich.
Aye.
Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Rolette, Commissioner Tamplin, Vice Chair Alvarez, Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff. We will now move on to Agenda Item 5, the items calendared for consent. This includes the approval of innovation projects from Santa Cruz and San Luis Obispo counties. Commission staff have sent the documents related to these projects to all commissioners at the time the September agenda was posted, and a copy of the staff analysis for both San Luis Obispo and Santa Cruz counties have been provided in your packet, as well as a letter of support received for San Luis Obispo. The San Luis Obispo project was shared by commission staff with community partners on July 17th and again on August 22nd. The Santa Cruz project was shared on July 14th and again on September 11th. There were no comments received in response to the sharing of both projects on these dates. As a reminder, any commissioner can remove an item on the consent calendar. That item would then be considered as a regularly scheduled agenda item at a future commission meeting. Before opening it up to commissioners for comments or questions on this item, I wanted to share some of my thoughts related to the San Luis Obispo consent item. First, I want to thank the county for bringing this proposal to us that would bring funding for behavioral health care services into residential care facilities for older adults. When we first looked at this project, we thought that nursing homes were already providing needed behavioral health services for this population. My thought was that this should already be happening, as they are required to meet all of their needs, both physical needs and behavioral health needs. There was a media article published recently in Los Angeles that presented concerns regarding older adults residing in nursing homes. I am troubled that this population may not be receiving the care that they need, but I don't think we should make San Luis Obispo wait and prolong efforts to meet the needs while the Commission explores the issue. This project presents an opportunity for the Commission to lean into this larger conversation about the needs San Luis Obispo has elevated and is trying to address. I would like to recommend that we approve this project on consent, and I am asking for an aye vote. I have asked the Commission staff to work with state agencies, policymakers, and advocacy groups to assess the concerns presented in this project and come back to us with the information. I would also like to recommend that we invite San Luis Obispo County and the county's long-term care ombudsman back to the Commission, maybe in 6 months, to discuss some of the challenges experienced that led to the development of this project. At this time, I would like to invite commissioners to offer comments or ask questions. Are there any comments or questions regarding these? Okay, I see none in the room. Any online? None online either. Commissioner? That's public. Okay, yeah, no, in that, thanks. So at this time, I would invite members of the public to make public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, I would ask that we limit the public comments to 3 minutes or less. Mariani, are there any public comments? Please raise your hand now, as the queue will be closing.
We currently have one public comment. Jeffrey, please go ahead, your line's open.
Hello, good morning, Commissioners. I'm Jeffrey R., representing the Santa Cruz County Mental Health Advisory Board, stating our position of strong support for the Crisis Now plan for Santa Cruz County. Our Crisis Now plan is a long overdue step to increase access to mental health services, improve the quality of these services, and promote interagency and community collaboration. It'll reduce people in crisis becoming justice involved. It's a plan based on essential elements, measurable standards, and best practices, including the training and employing of peers. The Crisis Now program has an initial start date for deploying mobile crisis response teams of January 2024. Santa Cruz County is working to achieve the Crisis Now goal of an ideal crisis response system commensurate with other services such as fire departments, EMS, law enforcement, and physical health care, in which anyone, anywhere, anytime receives the services they deserve at the intensity and duration needed to achieve a stable and meaningful life. Our Crisis Now plan is a step to achieve this goal, and it's an imperative that we take this step now. In closing, the Santa Cruz County Mental Health Advisory Board, along with the Office of Education of Santa Cruz County, Watsonville Community Hospital, NAMI of Santa Cruz County Sheriff, Santa Cruz City Police Department, and others strongly support the Crisis Now MHSA Innovation Plan for Santa Cruz County and urge you to approve the allocation of MHSA funding for our plan. Thank you for your work and service in overseeing the continuous improvement of behavioral health services in the state of California.
Thank you, Jeffrey.
And we got one last public comment from Richard. Your line's open.
Good morning, Commissioners. Richard Geller from Santa Cruz. I do not support the plan. I support the concept. My problem is that this was not a client family driven plan as an innovation plan. This was a county plan. As far as for peers, I don't see the numbers in the proposal, how many peers would be with the mobile crisis team, which I highly support, and part of the workforce. This is an issue with Santa Cruz County with the previous administration of behavioral health that would not put peers into the county workforce as with the general workforce of the behavioral health department. I'm truly disappointed. Hello, did I get cut off?
Go ahead, Richard, you may finish.
Okay, I don't know what part I was cut off. So basically, it was not a community engagement process with this plan. They need to follow the CPP process. Thank you.
Hi, this is Mark Carmetz, and the question I have is, I know somebody who walked up Highway 17, and I'm wondering if this would help that person, because she lived in Santa Cruz at that time. I'm purposely not giving any names. Thank you.
Sorry, everyone. We appear to be having some technical difficulties in the room, so just hang on a second. We'll be right back.
Okay, so we apologize. We understand that there was some technical difficulty. So let me start my last comment again. Now that public comment has closed, I would entertain a motion that the commission approves the consent calendar, which includes funding for San Luis Obispo, counties embracing mental and behavioral health for residential adult care and education, Embrace, and for Santa Cruz's Crisis Now Multi-County Innovation Project. Do we have a motion? Thank you, Commissioner Danovich. And a second.
I'll second.
Thank you, Commissioner Carnevale. We have a motion and a second to approve the consent calendar. Are there any additional questions or comments from commissioners?
Commissioner Mitchell.
Please,
I
Commissioner
have a
Mitchell.
question regarding Richard's question regarding Santa Cruz County. Can someone, at least from the county, tell me where the peers are in their proposal, since he was very, or staff, if that can be pointed out?
Yes, happily. I will ask Tom if you could, please.
Yes, staff analyzed this. We received Richard's comment last night, and so staff analyzed his comment and looked at the, did the analysis of the innovation plan and determined that the county is going to be incorporating peers into the program, and also determined that they followed all regulatory processes for a community planning process. So they're their plan incorporates peers into the Crisis Now model. It's a very important part of the Crisis Now innovation model.
So that's a misunderstanding on Richard's part, on his behalf.
Yeah, all I know is that our staff talked with county and was it Santa Cruz County and the consultant that's working with them on it. It looks that they've followed all the processes that they are supposed to follow, and they're following the model as it's been put together. And a big part of the mobile crisis model is to include peers in that process. It's a very effective approach, and we learned that through our own SB 82 triage mobile crisis teams, that peers are a big important part of that process.
Okay, thank you, Tom.
Oh, I'm gonna.
Thank you. So we have a motion to approve and a second, and Commissioner Mitchell, are we good to move forward?
Mm-hmm.
Thank you. So Jeff, I would ask then that you please call roll.
Commissioner Bontrager. Commissioner Brown. Aye. Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers. Commissioner
Aye.
Chen. Oh, I'm sorry. Sorry, Commissioner Chambers. We got your aye vote. Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell.
Approved.
Commissioner Robinson.
Aye.
Platt. Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal-Weiss.
Aye.
Chair, the motion passes.
Thank you, Jeff. I want to thank Santa Cruz again, and thank you, San Luis Obispo, for your work on this project and bringing this issue to our attention. We look forward to seeing you in approximately 6 months to have a conversation about the gaps in care that older adults with behavioral health needs may not be receiving. Staff will reach out to you as we approach that time frame and coordinate next steps with you. So thank you, and let's move on to our next agenda item. We will now move on to agenda item 6, where the Commission will hear a panel presentation on substance use disorders. Yesterday, the Commission participated in a site visit where they accompanied street medicine teams who provided SUD treatment in the Skid Row area and Los Angeles General Hospital, where they toured the ER and had a roundtable discussion with treatment experts about the specific barriers to treatment. The work being done downtown is inspiring and also eye-opening. Today, we want to continue this discussion about opportunities to identify gaps and to support programs across the state that will address some of the barriers to accessing care that we heard about yesterday. Commissioner Danovich, before we turn it over to the panel, I wanted to provide you with an opportunity to share your thoughts on yesterday's site visit, and also where you feel it would be important for the Commission to focus its attention.
Great, thank you. I would just say really briefly that this is a long overdue initiative. As we all know, historically, substance use services were separated from mental health services, were separated from medical services, and we all deal on a daily basis with the unintended consequences of those separations as we try to piece the system back together. That separation was also built into this act when it was first written, and that's now been remedied so that this act can be used for all mental illnesses, not just mental illnesses that don't include substance use disorder. And so it's very exciting to have an initiative that focuses on that. Staff did a really terrific job of putting together an outstanding set of, what do you do? How do you give the Commission a glimpse of substance use disorder in a day? It's sort of an impossible act, but they put together a really, really compelling and intense and moving day. And part of what was so moving and intense and compelling about it was, seeing firsthand the incredible work that's done on a regular basis on the front lines of this city, dealing with the problems that exist all across the state and the nation. So really appreciative for that, and look forward to hear from our panel about each of their views of the system and opportunities, and I think that once the commission decides to move forward with designating this initiative to substance use, we can specifically hone in on what opportunity we want to tackle, recognizing that everything we're going to hear about is really compelling, and we need to figure out what we can bite off or we can have an impact with the resources that we have and given the constraints that we deal with. So thank you, and turn it over to our panel.
I also would like to invite any other commissioners who joined the site visit to share their thoughts.
Madam Chair, I found yesterday, as someone who does not work at all in the system, so it was my first exposure, I found yesterday to be hugely impactful on a personal level and certainly impactful in terms of our role here at the commission. You know, I commented to somebody last night, I was texting, I said, I observed a day where we are traumatizing the traumatized, because my lens on this is through the neuroscience, what I know about the neurobiology of the brain. And my view of this is that everyone on the street is in crisis mode, and this just highlights the continuing inequity between how we treat health care in every other part and how we treat mental health, and that mental health, that the brain that is the root cause of the mental health is not being treated like every other organ. If when people have heart attacks, we rush them to the hospital and stabilize them, and then once we've stabilized them, then we deal with the other issues. But here, I just saw people all over the place having heart attacks, and we were asking them to go through assessments and fill out forms and trying to navigate a system that, you know, I couldn't figure out, and they're in their fight and flight mode. It's no wonder why that they are in crisis. And so it just makes me wonder, how is it that yet again we have a broken system that's not better coordinated? And at the same time, to see the heroic effort of all the people on the streets who are trying to work in this incredibly broken system to deliver services to people who, you know, they care about and love. And, you know, and I'm sorry I'm going on, but, you know, the thing that I kept being struck by were several people saying, you know, these people have hopes and dreams and aspirations, and I think it's easy for all of us not to see these people as human beings anymore that have hopes and dreams and aspirations, and I think it makes them human, and it's a reminder of how important they are, and that if we can address the needs of these people, then we should be able to address everybody's needs. And so I just thank you for the opportunity to participate yesterday.
Thank you, Commissioner Carnevale. Any other comments? And we can make comments too afterwards. I want to thank you for being here. I know it was something, I work in schools, and so one of the things I kept talking about, continuum, and how do we get to prevention, and but it's the lives, right? It's the lives. Nobody wakes up and wants to live this life, and yet there's such judgment around SUD, and I think that's a societal thing. We place judgment, like people made these choices to live like this, and I look forward to learning what we can do. In my own personal life, I'm dealing with a family member, and so how do we address this? Because it can't be about judgment. We can't just make assumptions and then not move forward. So thank you for being here today, and I'm going to hand it over to Tom to get us started with this.
Thank you, Chairman Adrugawais and Commissioners. I want to get right to the panel, but first I'd like to provide you with a brief background on the funding that's available for the Commission to support the substance use disorder efforts, how we've allocated the mental health wellness funds in the past, and then outline some of the goals for today's discussion. On the funding piece, the Commission has their budget includes $20 million per year through the Mental Health Wellness Act to provide grants to programs that address crisis prevention, early intervention, and crisis response services. In October of 2021, the Commission identified 5 priorities for these funds: strategies to reduce unnecessary hospitalizations, Also programs to meet the behavioral health needs of older adults, substance use disorder programs, opportunities to support services for children 0 to 5, and peer respite programs. Last year at this time, the Commission allocated 2 years of funding, $40 million, to expand mobile support programs for older adults through AgeWise and PEARLS programs, and to expand the number of empath crisis stabilization units that are adjacent to and on the grounds of hospitals. So our goal in assembling this panel of experts is to assist the Commission as it explores opportunities to identify, fill gaps in the continuum of care or address barriers that we heard so much about yesterday in accessing substance use disorder services. So $20 million is not a lot of money to address all of these needs, all the needs that exist in California, but it does provide an opportunity for the Commission to expand SUD approaches that respond to urgent needs. It gives the opportunity to also potentially pilot new approaches, to incentivize partnerships where that needs to happen, and to support innovative approaches in financing and effective service delivery. So with that, I would like to introduce all of you to our first panelist. We'll begin with Tyler Sadwith. Tyler's joining us remotely. Tyler Sadwith was appointed by Governor Newsom as the Deputy Director of Behavioral Health at the California Department of Healthcare Services. Tyler's responsible for leading DHCS and all of their efforts to ensure high quality and accessible specialty mental health and substance use disorder services in Medi-Cal and other public programs. Thank you for being with us today. Tyler, you can go ahead and begin your presentation.
Thank you, Tom. And just to check in on housekeeping, I should share my screen and present presentation materials myself.
If you could do that, that would be great. Otherwise, we can do that. But if you can share your screen, that would be great.
Yep, I can absolutely do that. Can someone just confirm that you can see the presentation up?
Yep, we can see it. Thank you.
Excellent. Well, thank you and good morning, Commission members and everybody. I apologize for not being able to join in person due to prior conflicts, but I am privileged and grateful to be able to meet with you all to discuss this incredible opportunity. I think someone struck it well when they said we can't discuss all SUD funding in one afternoon. So hopefully this is the start of an ongoing conversation. I know we have other panelists that will be highlighting the excellent and innovative work that they are leading across the state. So what I'd like to do is sort of just set the table and provide some foundational context. First, I'll just highlight the various funding sources for substance use disorder prevention, treatment, and recovery resources in the state. Then I'll highlight the current landscape for substance use disorder innovation grant making, because DHCS is heavily involved in this space, and I think this is relevant for the Commission's discussion. Then I'll just share a couple starting point thoughts about some opportunities that the Commission might consider, and then happy to answer any questions or participate in a discussion. So I'm going to breeze through this. I'm going to go a little bit rapid fire because I recognize I have only about 10 minutes. So just as context, DHCS, the Department of Healthcare Services, is the California State Medicaid Agency. We also are the federally designated state single state agency for substance abuse and the State Mental Health Authority. We cover approximately 1 in 3 Californians, and the annual Medicaid spend from 3 years ago was about $600 million, and the grant funding was nearly $1 billion. These numbers are increasing. I'd highlight that the Medicaid expenditures for SUD services are sort of disproportionately smaller than they are for specialty mental health services, and that's something we continue to pay attention to. We also are at the department administering opioid settlement funding, which was not captured on the prior slide. So currently and through the next near future, we will be administering a few $1 billion that we receive through opioid litigation and settlements, the majority of which will go to cities and counties, and some will be administered by the state. To set the landscape for providers, we license and certify SUD providers. There are approximately 900 in the state. About a quarter of them participate in Medi-Cal. We oversee ASAM, American Society of Addiction Medicine, level of care designation for residential providers. There are about 800 certified outpatient providers, about nearly half participate in Medi-Cal. Prior to this year, certification for outpatient providers was optional, but the Budget Act of last year requires outpatient providers to obtain certification, so this will be mandatory. Medi-Cal, as I'm sure everyone knows, has a complicated delivery system for behavioral health services. Some behavioral health services are delivered through managed care plans. Some are delivered through non-risk, non-capitated managed care plans that counties administer as mental health plans. Those are specialty mental health services. For substance use disorder services, historically, they were administered through a fee-for-service carve-out program with a limited benefit. But as I'll walk through, and I know Dr. Sai from Los Angeles will highlight, the Drug Medi-Cal Organized Delivery System, or the DMC ODS, covers at this point 97% of the Medi-Cal population, where 38 counties voluntarily participate as managed care plans to deliver a comprehensive benefit aligned through the ASAM criteria. So just as background, this is a CMS flexibility to cover services not otherwise coverable under Medicaid, including residential treatment and IMDs. We received approval in 2015. ASAM is really the pillar and the cornerstone for it. And right now, California was the first state to receive this type of approval, and 33 other states have followed our lead. At the moment, DHCS is pursuing a similar opportunity to expand mental health care in Medi-Cal under the BH Connect demonstration. We plan to submit that to CMS later this year, and we just concluded our public comment period. This provides a snapshot, sort of a comparison of what used to be covered under Drug Medi-Cal. It's a limited benefit, and what is covered now in the comprehensive benefit package available for counties that participate in the Drug Medi-Cal Organized Delivery System. So as you can see, 97% of patients have access to services they don't otherwise have access to, including recovery services, care coordination, residential treatment in IMDs, contingency management, and others. Some initial findings include some positive outcomes, including high patient satisfaction rates, a 30% reduction in re-overdose rates, and increases in 30-day retention in treatment. We also know that the patients are ending up accessing levels of care that track and that align with their initial screenings and their initial assessments. So more information is available in our independent evaluation. One interesting innovative benefit I want to highlight in the DMC ODS is we were the first state in the nation to receive approval to cover contingency management in the Medicaid program. We have 24 counties covering 88% of Medi-Cal opting in to implement contingency management, which is the intervention with the strongest base of evidence for improving outcomes for individuals with stimulant use disorder. This is not only incredibly important because stimulant use disorder is something California has historically and continues to grapple with meth use, but also because overdose deaths continue to primarily involve combined use of stimulant use disorder and fentanyl. So this is a key intervention in our overdose response strategy. So now I'd like to just sort of highlight the current landscape for SUD innovation grant making. I think this is helpful context because my hope for today is that the Commission sort of understands and gets excited about those opportunities in the SUD innovation space where the Commission could align with or build upon or leverage opportunities the department has not covered today. But I want to highlight that under the California MAT expansion project, we have been administering hundreds of millions of dollars of federal SAMHSA grant funding to really invest in the prevention, early intervention, treatment, recovery, and harm reduction continuum across the state, where we're accelerating the implementation of evidence-based practices and engaging all sectors of the healthcare system, not just the specialty SUD providers that historically had remained responsible for addressing this issue. So just as context, the Congress started passing state opioid response grants in 2017. They continued to pass these, and since then we have administered $650 million in SUD grant funding across the state. These have resulted in 174,000 new people receiving evidence-based medications for addiction treatment, including 25,000 patients receiving treatment for stimulant use disorder. We have expanded access points to medications for addiction treatment in 650 locations across the state. And we currently administer 30 projects that, again, cover opioid use disorder, fentanyl awareness and interventions, naloxone distribution, and stimulant use disorder strategies specifically. Our website has information about all of these innovative programs. They include everything from providing funding and TA to FQHCs and primary care centers to implement MAT, working with emergency medical services to initiate buprenorphine, supporting warm lines for clinician-to-clinician consultation on substance use disorder, and the California Bridge program, which Dr. Mullen will describe, where the majority of hospitals have implemented MAT and navigator services in the emergency departments. We have supported 37 counties to implement MAT in their jails. We have provided sort of an equity-anchored approach to supporting MAT and substance use disorder awareness, prevention, treatment, and intervention in community-based organizations across the state, including those that primarily serve populations experiencing disparities. And I'll highlight a few of these as well. The Naloxone Distribution Project has distributed 3 million units of naloxone, resulting in over 200,000 reported overdose reversals. I mentioned the expanding MAT in jails, drug courts, and county criminal justice systems. I apologize, I said 37 counties. This is actually 41 counties have participated in this project. And the MAT access points really has focused on engaging those communities that historically have experienced disparities and specific communities across California through targeted messaging and outreach to support local infrastructure to reach communities most at need and historically underserved communities. And Dr. Mullen will highlight the California Bridge program, which has just achieved incredible results and where California is a leading state in the nation. So in terms of opportunities, I would highlight that I think a top opportunity for the commission to consider is expanding access and the infrastructure for low threshold or low barrier treatment providers that provide medications to addiction treatment, which have the strongest evidence base. Right now, accessing medications for addiction treatment and treatment can be challenging, and due to insurance requirements and operating hours and prior authorization and extensive assessments, sometimes folks drop out of treatment or don't show up or don't stick around. So one immediate thing that can save lives in California is supporting our SUD providers and other healthcare providers to offer low barrier access to outpatient medications for addiction treatment. Some of these exist in California today, and I think this is a key opportunity to scale and expand. One other opportunity to consider is integration with substance use disorder and medical care. There are a couple bright spots in California where SUD providers have become federally qualified health centers and provide fully integrated care. This is not only great to provide and meet the provide great care and meet the needs of patients, including patients managing infectious diseases, but it also enhances revenue streams for substance use disorder providers, which is key to supporting scaling and sustainability. So I think this is something I've personally been interested in, and I haven't seen California nudge this or provide resources to SUD providers to pursue this. And the final area for opportunity for consideration from my humble perspective would be supporting the specialty SUD provider network to develop clinical competencies to be what is called co-occurring capable by ASAM. Co-occurring enhanced providers. Co-occurring capable providers are SUD providers that are able to treat patients with co-occurring mental health conditions that are manageable and that are not severe. What this means is that individuals with co-occurring conditions with complex or serious mental illness that are not managed or stabilized are often unable to be admitted to addiction treatment centers. So supporting SUD providers to become co-occurring enhanced, which is a term from ASAM, to be able to really meet these needs of patients with dual diagnoses would improve outcomes for Californians across the state. So I know that was a lot of information, and again, my number one hope is that this is an opportunity to start the conversation. The department looks forward to continuing to support the commission with assessing opportunities for the SUD Innovation Grant funding. Thank you.
Thank you, Tyler. Appreciate it. That's what we're looking for today, is just specific opportunities like you just laid out. And so with that, I think we'll move to our next panelists and hear from Dr. Gary Tsai, who you referenced. Dr. Gary Tsai is the Director of Substance Use Prevention and Control, a division of the Los Angeles County Department of Public Health. In his role, he oversees a full spectrum of substance use programs, such as harm prevention or harm reduction and treatment services for the 10 million residents of Los Angeles County. Thank you, Dr. Tsai, for being here today.
Thank you. Thank you, Commission, for your interest in this topic. I'm very happy to be here. I'm going to run through my slides relatively briefly because I do want to spend a little bit of time providing some more concrete ideas around how some of these funds could be leveraged in a optimal way. I have a couple goals today. One is so that the Commission gets a better sense of what the specialty SUD system does. And then two is to highlight what some of the opportunities are in terms of investments. The first couple slides are more background in terms of what my agency does, which is similar to what a lot of especially SUD agencies do across the state, which is overseeing the specialty prevention and treatment and recovery systems. We also offer a fairly expansive network of harm reduction agencies here. There's some variability across counties around harm reduction, but that's essentially the scope of our responsibilities. One way to think of the specialty SUD system is similar to the specialty mental health, except it's focused on SUD issues. As Dr. Danovich had highlighted, the Medi-Cal carve-outs, are carved out according to physical health, especially mental health, specialty substance use, also known as drug Medi-Cal. And so drug Medi-Cal is essentially what specialty SUD systems oversee. This slide is actually very similar. You'll know that Tyler and I do present quite a bit together, and so this is a similar slide to what he had presented, so I'm not going to go through it in detail. I think the main takeaway is that with implementation of the drug Medi-Cal organized delivery system back in 2017, which was when Los Angeles County implemented, the scope of services covered under Medi-Cal expanded significantly. Previously, and this was just 2016, right, which isn't that long ago, only perinatal women could receive Medi-Cal reimbursable residential substance use treatment. If you were a man who needed residential substance use treatment, Medi-Cal would not cover it. And so I highlight that because 2016 is not that, it's only 7 years ago or so. And so I think that that gives us a good sense of where the drug Medi-Cal systems are starting from and the work that we have ahead of us. One of the key changes with the drug Medi-Cal organized delivery system waiver was also how we were financed, because similar to the waiver that specialty mental health systems implemented back in 1995, the ability to leverage Medi-Cal as the primary payer of services allowed us to identify and use other funding that we were using to pay for SUD services in other more expansive ways. And so the key change with, one of the key changes with the drug Medi-Cal waiver was drug Medi-Cal becoming the primary payer, all of our other secondary sources then being able to be leveraged for other things, other priorities. This slide highlights the various levels of care. So when we talk about a continuum of services, earlier I had mentioned that we're responsible for the prevention system. We work with networks of schools. We work with Department of Parks and Recreation. We work with libraries, in particular around positive youth development programs, peer leadership programs to really invest upstream in our youth. This slide highlights our treatment system. And so when we talk about the continuum through the treatment lens, we're talking about different levels of care, whether they're recovery services, outpatient services, intensive outpatient, different intensities of residential services, different intensities of withdrawal management, otherwise known as detox, or opioid treatment programs, which are otherwise known as methadone clinics. We also offer things outside of the Medi-Cal benefit, such as recovery bridge housing, which is recovery-oriented housing for individuals who need a safe, recovery-oriented living environment, oftentimes because they are experiencing homelessness. Some of the numbers highlighted here highlight the outcomes of the drug Medi-Cal waiver and what we've been able to do, largely because we've been able to leverage Medi-Cal, saving 50 to 90% on the dollar, and reinvest those other monies elsewhere. So our prevention budget has increased by 260%. Our treatment budget has increased by 275%. We've increased residential beds by a significant amount. Sorry, I don't have my glasses with me. And recovery bridge housing, which was really a benefit that previously was wholly covered by the county, which is still covered by the county, but we expanded beds significantly there as well. And our harm reduction budget expanded by 500%. So this just highlights the expansion that's occurred since implementation of the waiver, and there's a lot more room for us, a lot more work for us to do to grow the SUD system so that we can actually achieve the integrated behavioral health system that we've talked about across the state for many years now. So to highlight some of the opportunities, one of them is CalAIM. I'm not going to get into details about CalAIM just because, although I'm happy to talk about it later, I think that there's been a lot of time spent on CalAIM, but just to highlight, there are a lot of different arms or pillars of CalAIM. One of them is payment reform, which I do think is a very significant opportunity for us to be smart, strategic with the way that we're financing our behavioral health system as opposed to approaching financing from a more transactional perspective. One of the innovations and recent initiatives that we've launched is called Reaching to 95%. And what this highlights is that the majority of people with substance use disorders don't receive services. And the majority of those who don't receive services, and that's the 95%, say that they didn't receive services because they don't think that they need them. And so while we have supply issues on the substance use treatment side in terms of needing to grow capacity, right, and we've had some opportunities because of state investments, for example, through the Behavioral Health Continuum Infrastructure Program, behavioral health bridge housing, which is coming. We also have a very significant demand issue that I don't think that we talk about enough, and that's really what the Reaching 95% or R95 initiative is focused on. It's focused on ensuring that our treatment system is designed not just for the 5% of people who are knocking on our door, but for the 95% of people who aren't knocking on our door but really should be. And there are a lot of different components to this. I don't have time to go through all of the components, But just to highlight some of them are really maximizing outreach and engagement, expanding field-based services. These are Medi-Cal reimbursable services out in the field. Currently, we provide some of them in interim housing settings, but we can expand that significantly. And because it's Medi-Cal reimbursable, are able to leverage the federal financial participation or the federal match. Other components of R95 are really operationally working with our treatment provider network to re-examine admissions and discharge policies with the aim to lower the bar for admissions and raise the bar for discharges. And specifically what I mean by that is that right now a lot of substance use treatment agencies, and this is across the nation, right, require abstinence in order to be considered for treatment. And I think that society at large has associated abstinence, readiness for abstinence with readiness for treatment. We need to break that. And the reason why we need to break that is because it's too high of a bar. And it's akin to saying to someone with diabetes that unless your blood sugar is below 200, you're not ready for treatment yet. Come back when your blood sugar is below 200. And clearly, in our primary care clinics, we don't do that. If someone comes in with a blood sugar of 600, we say, wow, you really need our help. Let's get you on some medication, talk to you about, lifestyle changes, right? And so that's a fundamental aim of R95 is addressing that. And in terms of raising the discharge bar, similarly, people oftentimes are discharged when they relapse. Now, there are some times when that may be appropriate, but there are other times where I think we're too ready to discharge individuals for exhibiting a symptom of their condition. And so that's another element of better reaching the 95%. So it's about creating the environment and also other focuses, for example, on things as simple as lighting, right? Sterile white lighting is less welcoming in general than soft white lighting, paying attention to furniture, paying attention to kind of the environment that we create for those who have been in environments that have been inviting. The whole goal of every interaction we have with clients with SUD should be about how we better engage those individuals, right? And so that's the aim of R95. Just to jump briefly, I do think that with this opportunity and there's some other slides here about our payment reform approach, which incorporates the R95 initiative. But because of the level of detail in our time, I'm going to just breeze through those and spend the last couple minutes focused on, I do think that there's a tremendous opportunity here for the Commission to consider investing these funds broadly, consistent with the continuum of services that are needed to address the varied needs of the population we serve, inclusive of prevention. And so, SUD systems have been underfunded for many years. Tyler had mentioned the disparity between specialty mental health funding comprising 90% of the specialty behavioral health budget under Medi-Cal in California, and drug Medi-Cal comprising 10%. That has resulted in a lot of things. One of the things that's resulted in is a system that really needs to grow and hasn't had the resources to, for example, hire prescribers who can offer MAT. That's why one of the things that you'll hear, I believe, from this panel today is that one of the investments really should be around how we scale MAT in different ways, right? Within the specialty SUD system, outside of the specialty SUD system. And so I do think that there are different ways that we can do that. We have a cost-sharing program that we're considering right now that I think would be a worthwhile investment to address the primary barrier of specialty SUD programs in not being able to hire anyone because they haven't had the resources. And because we just implemented payment reform, there's an opportunity for us to build this runway where we share costs for the first year, maybe 70 to 80% of that cost, and then next year bring that down to about 50% or so that buys those agencies a couple years to stabilize with the higher payment reform rates and then sustain that staffing. And we continue to do that in order to grow the number of MAT prescribers within the specialty SUD system. I agree with Tyler that there are important opportunities to invest in low barrier MAT access. Some of that, I think the Commission had an opportunity to see yesterday in terms of street-based services. That would be a worthwhile investment. I also agree with the investment in FQHCs. and how we can grow capacities there to supplement the core SUD services provided in the special SUD system. On the prevention side, I think that there are a lot of opportunities to invest in our youth, in particular with positive youth development programming and leadership development programming. This quote, I think, highlights why that's important in terms of the opposite of addiction not being sobriety, but the opposite of addiction actually being connection. And to the extent that we can build those connections among our youth, we can prevent some of the downstream issues. Although I do think that a lot of the funding would need to focus on things on the treatment side, just because we are in the worst overdose crisis in history, and we need to be making decisions accordingly. And so last night after our site visit, I did spend some time writing up a brief proposal for how funds might be spent. Happy to go over those details, but I know I've probably spent more than the allotted time. So thank you.
Great, thank you, Dr. Stein. We will have time for discussion after all the presentations. But now I'd like to introduce Dr. Rebecca Trotsky. Sir, first of all, thank you so much for organizing our site visit yesterday. As Commissioner Danovich said, it was compelling and very helpful to see that. Dr. Trotsky, sir, is a physician in family medicine with a subspecialty in addiction medicine. Currently she's Director of Addiction and Community Medicine at the medical Director of Jail Ward Services at Los Angeles General Medical Center, which we visited yesterday, and the Los Angeles County Department of Health Services. Thank you for being here. You can begin.
Thank you. I think one of the things that this highlights is
Yeah, there you are.
Hello, I learned technology. So happy to be on this panel. You have a wide range of experts, and many things are true at the same time. Both we need to increase funding and support and training for the specialty addiction medicine services, as well as all these other things. So yesterday we saw a bunch of system failures, and at the same time the system is working really well. So there's two things that are true at the same time. I really want to highlight the all-in access for addiction care for people who show up wherever they show up, whenever they show up, and that's, I think, what we'll hear over and over again, that we need to meet people where they're at, no matter what. So we know that substance use disorder is common among people who have mental health issues and behavioral health issues. It's comorbid, and in specific, more and more we're seeing the role of stimulants co-occurring with psychosis and schizophrenia, which we saw a lot yesterday in the streets. So that really significant, severe behavioral health issue we need to address on both fronts. And right now there's challenges and difficulty when we have a fragmented care delivery system that tends to focus just on one element. We have talked a lot about how people are experiencing homelessness at an increasing rate at the same time as the counties are getting better and better at delivering services to that population. So many things are true at the same time. So why don't people just stop using drugs? There's a lot of behavioral issues and there's a lot of brain changes that happen. And with opioids, one of the magnificent technologies that we have at our disposal are medications for addiction treatment that help normalize and regulate the brain. When my patients tell me that they've started Suboxone or buprenorphine, which is a treatment for opioid use disorder, they tell me they feel like their old selves again before they started using drugs. They tell me like they felt like a 15-year-old again, and this is exactly what I want for them. I want them to be able to be stabilized, to feel well again. And we know when people don't have these medications, as best as their intentions are when they leave a rehab program that's focusing on abstinence, they get back to the same people, places, and things that trigger their use, and they return to their use patterns. So it's important to understand that our social story around addiction, that you just have to work hard enough and pray hard enough and stop using drugs and it's a behavioral choice, that's a myth, and it's hard to undo those social stories. And part of the system change that we get to do is rewrite those stories as we transform healthcare systems. There's really three things that I do as a physician, and sometimes when you talk about this, you're like, this is really oversimplifying it, yet it's important to understand. Any disease, including addiction, you have three pillars that help promote health, and this also includes for general wellness. You have medications, you have counseling, individualized counseling with a trained expert, and you have support, and those supports can be housing supports. They can be a lot of different kinds of supports. When we're in the hospital system that you saw yesterday, a lot of the times we're focused on medications, that what we have available, And for opioid use disorder, this is one of the most extremely effective treatments. So medications alone will help people make those behavioral changes in their lives for opioid use disorder. That is not the same for other kinds of substance use disorder, like some of our stimulants. We're still working on those medications. We have some, they're not as effective as buprenorphine and naloxone. So it's important to recognize that depending on the substance use disorder you have, those sides of those triangles are bigger or smaller. Opioid use disorder, medications, and that's why we were really focused on how do you get medications in mouth and that last mile connection, and how do we start them from any and every point. So I always want to just remind people what buprenorphine is. If you have not heard about it, I could talk about it all day. She is our queen. So buprenorphine is a medication that when you put her in your mouth and take it every day. This is the graph that really transformed my medical care. So 30 days post-ER stay or 30 days post-hospitalization stay, people have health outcomes that are good and bad. Looking at mortality and norming the all population mortality as one, right? Like, so after 30 days, some people will pass away. That rate is gonna be just 1. When you have opioid use disorder, that rate is 6. So you're dying 6 times higher just because you have opioid use disorder. And that's with our standard system of care. So you got a photocopy of a 1-800 number, please stop using drugs. You got the referral to your primary care doctor that maybe did or did not have time to see you. You got connected to Gary Tsai's wonderful treatment programs, but maybe you went, maybe you didn't go. If you don't get medications for opioid use disorder, you will have a 6 times higher rate of death within 30 days, leaving the ER, leaving the hospital. When you put medications in mouth, that decreases 3 to 4-fold. So that's that blue line underneath there. And those medications, there's really only 3 medications. You've heard methadone, which is a full-on opioid that kind of helps regulate people's cravings for opioid. Buprenorphine's this queen in the middle that's both on and off that opioid receptor, helps stabilize that opioid part of the brain. And then you have naltrexone, which is basically like a long-acting Narcan that's completely blocking the opioid part of the brain. Those are the only 3 medications we have for opioid use disorder. They are all equally effective. Buprenorphine has a number of regulatory mechanisms that make it more elegant and able for physicians like myself to prescribe it and people to pick it up in pharmacies. Methadone is one of the most highly regulated, federally drugs available, and it requires people to go to a special center, a methadone clinic, and show up every day to get medications. There's a lot of jumps and hurdles for people to access methadone. It's an amazing medication, and we've put a lot of barriers in place that will be hard to undo. That's why I focus on buprenorphine. Once you understand kind of the importance of medications for reducing death and reducing lethality and improving wellness for people who have opioid use disorder, which, as Dr. Tsai was saying, is one of the most increasing causes of deaths in our community, you understand how important that medication is. First line, first thing, we need it at the door. We need it in the ERs, we need it in the hospitals. We need every single clinician to feel comfortable and confident providing that to their patient. Maybe we're recognizing that patient needs care at time of OB care, maybe it's a pediatrician, maybe it's during cancer treatment, maybe it's during surgery. All of these things, it's important for those providers to be able to be fluent in providing care, and if they're not,
Sound?
I lost sound, James. I cannot hear them.
Okay. It's been kind of hard. Are you having problems hearing too?
It just went out for me right now.
Okay.
Me too.
So we're not alone. Here. Let me, I'll text Toby, let him know that you can't hear. I just sent him a text. he says they're working on it.
Thank you.
Thanks for the update.
Yep.
Thank you. Please hold. We're having some technical issues and we will be with you shortly. The meeting has been paused.
Thank you.
Cultural story.
of that, I think we are up and ready to go, so we'll get going again here.
Brilliant. Thank you, everybody. So thank you so much as my brilliant prior comments, so amazing. So I have here, this has become our screensavers at the Department of Health Services, which highlights our medication for addiction treatment consult line. This is a 24/7 available line to all of our clinicians. And you heard yesterday from our pharmacist who said prior to the existence of this line, he was delivering in Skid Row 1 or 2 prescriptions a month for buprenorphine. And you can say, well, was that because we didn't have an addiction problem in Skid Row? Was that because we were so amazingly blessed that there wasn't that problem? Or was it because we did not have access to treatment? And the latter is significantly true. Once we delivered this low barrier, anybody can come all-in access point, his prescriptions for buprenorphine are now 10 a day. So we just, like I said, we wiped out downtown LA from the available treatment centers our first day of operation because we lowered that threshold and we made it widely available for clinicians and for the community. And this is the kind of treatment that I think is easily scalable. Everything that Dr. Sai said is also important. We need these foundational supports for our community. And the wonderful thing about your commission is that you have an opportunity to fund these edges and these innovation points that are super high yield. If this kind of model was available in every county, it would allow that expansion as quickly as we were able to expand in Los Angeles. One of the important things was it was an all-in thing. So it didn't need to have you be a signed up member of Medi-Cal. It did not need you to be a signed up member of my healthcare system. It was an all-in point. In addition to accessing treatment, you also saw yesterday the importance of having messaging around, so you still are continuing to use drugs and I still care for you, and these are the ways to do things more safely. So there are a set of universal precautions for the safer use of drugs. And this is something that's really hard for providers to understand. It's really hard for certain community members to understand. It is not hard for drug users to understand that there's a safer way to use drugs, and can you please help me get there? Building the bridge between those communities is significant. So the message is, start low, go slow, use with a friend, have naloxone at your side, test your drugs for fentanyl. These are all important messages that we all can be providing. So whenever I see a patient who uses drugs, this concept of are you ready for treatment no longer exists. This is the universal message I'm giving everybody. Like everybody, when we were in COVID, we were all wearing masks. We were all doing universal precautions to stay safe. When people use drugs, we're doing universal precautions to stay safe. These are some of the messages I want to give to my community. And it's no shame one way or the other. I have treatment available for you. Here it is, rather than let me give you a 10-page questionnaire to see if you're ready to accept my question, my services. If I am simply saying, I have pizza, are you hungry? That's a very different message than saying, let me assess your hunger, on a 10-point scale. So yeah, would you like to be put on hold for 2 hours to see if you can be eligible for pizza, right? Like, it's a different message. So it's super important to be able to deliver all of these things. And, I say them very calmly and, they're now part of my everyday. But when I first started 7 years ago, this was new to me and I stumbled over my words and I needed leaders to help, like providers and Dr. Gary Sai's team really to help coach me through how to do this effectively, efficiently. We saw how busy that ER was yesterday. We need to be able to do this in 5 minutes. We can't wait 50 minutes and back everybody up more and more and more until the hallways. The other universal safer use of drug precautions that I always tell people are things like never use alone. There's hotlines that you can have available. The opioid overdose naloxone, which you all will get today. It's that message of keep calm and carry naloxone. Like, I hope that you reach health in all these different ways. And also here's the other message. So I think that's the end of my slides. Thank you so much. I'm sure we'll have lots of conversations. Dr. Amy Mullen.
Great, thank you, Dr. Trotsky. Our next panelist is Dr. Amy Mullen, a professor at UC Davis with a dual appointment in the Department of Emergency Medicine and Psychiatry. She is board certified in both emergency medicine and addiction medicine, and is the founder of California Bridge, an effort to expand low threshold access to treatment for people with substance use disorders. Thank you for being here.
Thank you. I really appreciate the opportunity to speak to you all.
So I started out, I'm an emergency physician. So what you said, Commissioner, really resonated with me is this is, we take people with heart attacks very seriously. And I think the same for people who are using drugs. The 1-year mortality rate for someone with a heart attack is the same as someone with an overdose. And so I really need to think about this as someone who has a life-threatening emergency because it's the similar mortality. And so as an ER doctor, yes, that absolutely resonates me. And should we be scooping folks up and getting them started on treatment now? Absolutely. I 100% hear you. And that to me is equity, is to recognize that this is a treatable, life-threatening emergency and should be treated with the same resources and urgency as a heart attack because the mortality is the same. This is what I talk about this a lot, and this is really the motto of California Bridge. All people deserve rapid access to evidence-based treatment. And I think I see your heads nodding, like this resonates with us. But then let's dig in and think about how well we do this. All people. What if you have out-of-county Medi-Cal? What if your Medi-Cal card is expired? What if you don't have an ID? Transportation, the ability to show up on time. You don't have a cell phone with Wi-Fi access. And to think about how many people we are missing and excluding based on the system that we have developed. Rapid access. And to me, thinking about the mortality of someone with an overdose needs to be rapid, and that means now, not pizza next week. That needs to be treatment now, on demand, when you are ready and when it should be available. And that's what I think about as an emergency physician. This is a treatable, life-threatening disorder, and we need to provide rapid access to evidence-based treatment, and for me, that means medications. As you heard Dr. Trotsky, sir, mention, we have remarkably, shockingly effective medications, particularly for opioid use disorder, that are highly effective in managing people's symptoms, keeping them into recovery, and saving lives. And this is, you've all seen this, the ever-climbing overdose death rate. And I think to some extent, we've gotten numb to this, that overdose deaths continue to climb. However, every one of those deaths is preventable because we have such highly effective medications. And so really, when you look at the overdose death rate, to me, that is just emblematic of our failure to design a system that works for people. And so all of those deaths are on us because we have not created a system that meets people where they are. This is the statistic you heard. 10.3% of people age 12 and older who need treatment for substance use disorder received any treatment in the past year. This is from the National Survey on Drug Use and Health. That means around 90% of people are not receiving treatment. That means we need 9 times the number of treatment options out there. So we cannot get there by tweaking at the edges. We need to radically expand treatment opportunities. Even less than those people who receive treatment actually receive life-threatening medications. The other piece that you heard, and I 100% agree with Dr. Tsai on this, is there's a myth of treatment resistance. So in the survey, they often say 90% of the people, the 95% who say they don't need treatment. That has not been my experience. In the emergency department, I will show you some of the data from the California Bridge program. We looked through and did our data dive. 85.8% of the people we offered treatment to accepted it. So people want help. They're just not able to access the system as we have designed it. We have designed it to make it hard to access, and we're excluding the people who need it most. This is Drug Medi-Cal, and this is basically the growth in Drug Medi-Cal from 2017 to 2021. This is the number of unduplicated clients served during that time period, and we're just not getting there. We're just not getting to that 90%. We really need to make a huge investment in our system to make MAT in particular available everywhere. This is the number of emergency department visits. So this is my own possibility of people that we should reach. 1.2, almost 1.3 million unduplicated emergency departments with an untreated substance use disorder in 2021. And if you think about this, substance use disorder is a huge driver of ED visits and a huge driver of harms in our community. If you think about motor vehicle collisions, substance use disorder is a driver. Suicide, one of the primary risk factors for suicide is an untreated substance use disorder. Firearm violence, interpersonal violence, heart failure, liver failure, all of these are driven by unmet needs for substance use treatment disorders. And so thinking about what is really the driver of a lot of illness and trauma in our society, it is our inability to meet the needs of our patient population in terms of substance use disorder treatment. And then the current system is really designed to fail, right? So we have long waits, prior authorization, complex assessment, you know this, disjointed, siloed care, and then really restrictive paternalistic treatment models. As we've mentioned, insisting on abstinence before you're able to access treatment. This is like saying to the diabetic, I need you to sign a contract saying you'll never eat another donut again before I give you insulin. Who's going to do that, right? And so thinking about like, how can we design a system that works for people, that meets them where they are, and recognizes substance use disorder as the chronic illness that it is. This is an evaluation that UCLA did of the SOR projects, the State Opioid Response Funding. And you can't see it because the writing is so well, but you'll see that bar on the left are the number of people who were engaged in MAT through our emergency departments. And the next one is the number of people who are engaged in treatment through the hub and spoke system. And so you can see, even in our emergency departments, this is just by going up and asking people if they want help. We're able to engage almost 3 times as many people as the hub and spoke system. And it really just tells me there is a huge unmet need and people want help. We're just not delivering it to them in a way that they can access it. This is our California Bridge program, 236,000 people seen for substance use disorders, 176,000 people identified with opioid use disorder, and almost 80,000 prescriptions written for buprenorphine in the emergency department. We've distributed over 150,000 naloxone kits. And I'm gonna have you talk to Tommy Trevino next, but he is our amazing substance use navigator that has made this all happen in terms of bringing people into the system. And the other thing I wanted to actually say about our California Bridge program is this was not supposed to work, right? People in the emergency department, providers are too busy. Providers are not educated. They don't know how to give out buprenorphine or provide addiction treatment. These are emergency physicians. They don't have time. They didn't have extra training. And this was when the X waiver was still in place and during the COVID pandemic. This was not supposed to work because you've been told that providers don't have time to do this. They don't want to do this. But over a couple years, we managed to get 270 emergency departments and countless emergency physicians to prescribe buprenorphine. People don't want help, but we have seen 85% of people that we just ask, do you want help? And 85% raise their hand and say, yes, today, I want help. And 170,000 of them, I'm sorry, almost 80,000 leave with buprenorphine that day, that minute. And so I think this puts to bed the myth of people don't want treatment and the myth that doctors can't do this because it can be done in the emergency department. And I really want to talk about like where do we go from here? How can we reimagine care for the people who need it and deliver care where they are? Because we've shown that can be effective when we deliver it where they are in the emergency department. And thinking about, this is our California Bridge vision of the system of care, which really thinks about where patients are and how we can bring this system to work for the patient, and to reach them where they are, be it the hospital, be it our criminal justice system, where they are in the community, but to provide that low barrier, low threshold, walk-in access point where it does not matter what county you're from if you have your Medi-Cal card or your ID. And to make a system that works for people with substance use navigators that can help fill in those gaps. And so what we would propose would be a network of low threshold clinics across California that would help bring people in the system, stabilize them, and so that they can go on to addiction care, but that we can meet that high volume need across the state, create an actual hub, which is where people can come in, access low threshold treatments, and then as they're stabilized, go back to primary care, the drug Medi-Cal system if that's where they want to go, but receive on-demand, low threshold access to treatment when they want it and make the system that works for people. I wanted to leave you with a story because I heard the talk about prevention. And for me, prevention is early intervention. And I think about this kind of like the early psychosis clinics. Back in 2020, we had a patient, Javier, he was 14, which is the same age as my daughter was that year. He came into the emergency department after overdosing 4 times. And each time we put him on a hold, said it must be a suicide attempt, 5150, eventually it was released and he went back home, overdosed, came back. And I sat there April 2020 with his mother, and remember, I'm the addiction doctor, and she turned to me and she said, "Isn't there something we can give him to make him stop overdosing?" And I still remember that moment of like, oh, I missed this. He had been ordering fentanyl, the blue M30 Percocets online through Instagram, having them delivered to the house, overdosing, and his mother would reverse him on Narcan, bring him in the emergency department. We started him on buprenorphine in that ED visit and then connected him to outpatient care. It didn't go well. He went to our outpatient clinic, was eventually signed up through the county and assigned to the drug Medi-Cal clinic, which is a methadone clinic. His mother called me a couple months later and said, "There's no worse place for a 15, 14-year-old kid to receive care than a methadone clinic." She says, "This is just not going to work for us." I hear you. So I did telehealth visits with him for a couple months. We got his Medi-Cal switched. We finally found a family practice provider who would provide him buprenorphine. I did not hear from them for a couple years. And then I heard from her, she called me 3 years later, just a couple months ago. He was missing his appointments because he'd made the high school basketball team and he couldn't go after school. And so I started doing more telehealth visits with him to make sure that he could continue on his buprenorphine. But it just kind of shows that to me is prevention, because I think about the different direction that your life takes if you finish high school on the basketball team versus if we don't catch you until you're 26, if you make it that far. And so I want to leave you again with this, all people, and you have a tremendous opportunity to expand the treatment network in the state of California. It is currently not working. And so what I would propose to you would be a network of low threshold clinics across California. The state has made a lot of payment reform with Medi-Cal. There are a lot of new features with CalAIM that I think could ultimately support low threshold clinics through the Medi-Cal system, but we really need to grow that network rapidly. Thank you.
Thank you, Dr. Mullen. And our last panelist is Tommy Trevino. Tommy Trevino is a certified drug and alcohol counselor who specializes in drug use with co-occurring mental health. He has 20 years in recovery and is dedicated to the service of parents with loved ones that struggle with addiction. He's a substance use navigator at UC Davis and serves as a mentor to other substance use navigators around and across California. And I met Tommy a couple of years ago. I think we were here in LA. And since then, when I heard about him and know about him, as he's a whatever it takes kind of person. And so I'm happy to have you hear from him. Tommy.
Yeah, thank you so much for inviting me here. My name's Tommy Trevino. I'm 65 years old. I started using drugs when I was in 7th grade. I know somebody over here said they work with high school students or students, and that reminded me back when I first started when you said that, and it reminded me that even then I couldn't reach out for help. Even then, my parents and everybody else marked me as a drug addict at that age and put me in a place mentally where that's all I was going to be. So anyway, long story short, I went through school and chipped on, smoked marijuana on and off, started drinking in high school, graduated high school, got into cocaine, got married, that kind of thing. Got real heavy into drugs, cocaine, acid, different things like that, kept drinking. Long story short, my wife finally had enough of me at the age of 35, divorced me, and then I moved from Fresno area to Sacramento. I stopped using for 2 years. I look back now, didn't have any support, but I stopped. You know, I wanted to get my life together. I stayed sober 2 years. In those 2 years, I was sharing with Tom, I worked so hard, drove truck, got a Teamster job, invested all my money into real estate, and I had 10 rentals. And somebody introduced me into meth, smoking meth. 2 years later, I found myself walking in the snow in Medford, Oregon. 130 pounds. I weigh a little more than that now, but goes to show you. And I just like woke up and go, what the heck's going on here? And I looked at myself and I go, man, this isn't me. This isn't me. How am I going to get out of here? But, you know, I ended up homeless, like what you shared earlier. It was just like, you know, what am I going to do? So I'm a very proud man, and I humbled myself to stop using drugs. I was going to stop, but every time I stopped, I would last like a week, and then I'd find myself either getting depressed or getting mad, getting angry, getting anxiety, and then I would run to the meth pipe and take a hit, and then I would feel normal. And that's when it finally hit me. You're a drug addict, right? So I didn't know where to turn to. So I went to the library there in Medford and started reading the first book. I was just out of luck. I started reading what I had to get through to get better. And it talked about emotions, that I was going to go through the depression, anxiety, and anger for a year. I'm not a doctor or anything, but that stood out to me. And I go, man, it makes sense. Every time I try to get straight, I get angry or mad and I use it and I feel normal. It made sense to me. But now it's self-medicating, right? So I came back to Sacramento and I told a friend of mine that worked for the state, my plan, she goes, I need a place to stay for a year. She goes, you can stay in my garage, but for trade, you have to remodel my house. I said, okay, that's a deal. And I told her, so whenever I would get in that depressed mood, she would go in the garage, Tommy, get up, come on, get up, take a shower, get something to eat. And whenever I get mad and angry, man, I'm leaving, I'm gonna go get loaded. Tommy, remember, she helped me. She helped me, she motivated me and kept me there. 10 months went by and I remember waking up one morning and it was like someone turned the light on. It was like, I looked around and I felt this big shame come over me. And it was like looking over and looking back and going, what the heck was that? That breaking point when I read, I finally got there and it was like, what am I going to do now? So I joined a church and I worked at a thrift store for $8 an hour. I remember getting my first check, $400, man. I was just so happy to get that check. And they had a job coach there and they talked to me and they wanted to know my life story. And I told them, they go, hey, you know, we support people and going to school. So they helped me become a drug counselor. They asked me if I wanted to do that. I didn't know if I can do it, but I went and visited a couple of schools and I go, man, I can do this. So it was a do or die for me. I was already 40-something years old. I have to do this. I put it in my mind, I have to do this or I don't want to end up homeless again. This is the do or die thing for me. And I put everything I had in it. I went to school. They paid for my internship. I worked at a community clinic in West Sacramento called Community Care. And I worked there for a year, got my 2,030 hours, took the state test, passed it by 1 point. I was so happy. I was just like, man, you know, so I got a job at a DUI program, started working with people with DUIs. And then people with mental health started coming in. And I remember getting $17 an hour by then. And then I go, what am I doing here? What am I doing here? I can't help these people with mental health, right? So it's all a waste. What am I doing here? You know, I knew about drug addiction. So I took a job for WellSpace Health at $13 an hour, working with people with mental health. I didn't have time to go to college and learn all this stuff. I had to do this now. Like Tom says, I had to do this now. So I had 50 patients, and my job was to make sure they took their medications and get them to the clinic and get them where they needed to go. If my job wasn't to get them to stop using drugs, I would go in their apartment and go, hang on, Tom. They would go ahead and shoot up some heroin or go ahead and smoke some weed. And okay, you ready? Let's go. As long as you weren't violent or anything. So I did that for about 3 years and I loved it. I loved it. I learned so much about mental health. I knew when someone was taking too much medication. I go, let's check your medication Monday through Friday. Today's Monday. Why is Wednesday missing? And they were seeing little possums in their room, right? Okay, I get it. You're over medicated. So I learned so much. Somehow Dr. Mullen found me and asked me if she goes, I have people that keep coming to the emergency room with drug addiction. We don't know what to do. We need some help. And I'm thinking, me, you know, I don't know. So I went down there to see her. And I go, this is a crazy place. I've never been in a hospital before, but people in the hallways, people in gurneys, doctors, and UC Davis is huge. And I go, what do you want me to do? She goes, you're the professional, you tell me. And I was just like, man, I don't know. So I looked over and I seen this gentleman, he was intoxicated. So I grabbed a small chair and I go, can I sit down next to you? Yeah, we're sitting and we're watching everything. Oh man, this place is off the hook, right? So anyway, I ended up talking to him for about 2 hours. We're like, he was a grandfather, he was divorced, and he had a good job, and he had a retirement check, but he was an alcoholic. And this is where community resources are so important. I knew enough people in the community to find treatment for him. Got him to treatment, and everybody thought I was a genius. I go, is that all I have to do? And I can do this, right? So every day I should wake up in the morning, I go, man, Lord, just let me help somebody today. Just let me help somebody today. And I love meth addicts because I'm a recovering meth addict. And when I would talk to somebody, I knew what they're going through. I knew what they were going through. And then half the people that were struggling with mental health, I knew them. It was like, Leroy, you go, Tommy, what are you doing here? I said, I work here now with one of my patients, right, my clients. So I was well involved with my community and it's pretty tight. I got to learn that so many things in the hospital, like Dr. Mullen. When I first started working at a retreat addicts bad, they were like, get this drunk out of here, get this alcoholic out of here. And I go, hey, don't you treat them people like that? And sometimes it got in an argument and they would call Dr. Mullen, you know, Tommy's mad again. And she would back me up. What'd you do to him? You know, just like, nothing. He wants medication. Well, give it to him. Give him what he wants. And it was just like, she always supported me in this. Now it's grown so big that I have 5 counselors working for me. I'm a supervisor and I still can't keep up. My youngest was 12 years old. We have an adolescent program now that we help out. I hired a veteran, VA, to help out the veterans. So I hired a mother that her daughter was alcoholic. So trying to get a round team in a hospital. And I feel so blessed to be able to do this. What some of my barriers are insurances. Most of our patients are Medi-Cal, right? So it's like there's different programs. Some programs, Christian-based programs, work well. They want you to stay a year, but you can't be on medication. You have to be 45 years old or younger. And you have to stay a year because they know it takes that year for your brain to kind of switch around and your dopamines to get where they're supposed to go. They know that, but a lot of people don't like Christian-based programs. You know, they don't believe in God or Jesus, whatever. And I tell them, just go for a year. Just go, get your life. This is your chance. A lot of people go and a lot of them do really well, get their lives back. But other programs that I find, they're only in Sacramento County. If I start trying to send someone to Fresno or the Bay Area, they accuse me of patient dumping. I have to be careful. And I've learned different ways, different tricks, but I have to be really careful and use the resources in my community. Some resources, you have to be high to go. Some resources, you have to have 4 days to go before they help you. Other programs, you need an ID. It's like, who's gonna have an ID? And I think about when I was homeless and stuff, and when I humbled myself to get some clothes to go get that job, and I asked for a cement job, I remember looking back, it was like, this is my chance. I humbled myself to get these clothes, and I thought I had the job. The guy interviewed me, and at the very end, he goes, no, he goes, I can't do it. And man, I go, why? He goes, can I give you some advice? Next time you go in an interview, can you get some better clothes on? And it just put me in a place where it was just like, man, I was trapped. So I dedicated my life and taking this opportunity that Dr. Mullen gave me to help anybody I can. Like Tom says, there is no such thing as no to me. If somebody wants help, I know enough people now where I can get them in a program. I make agreements with clinics. I know they have funding programs, and I know they have to have people. And so we're a better place to get them from the hospital, right? To get people. So, and we need a place for these people to go to. So we set them up. We have different programs, different agreements, give them 3-week prescription. That takes a while for insurances to switch. It all depends, like WellSpace Health is one Medi-Cal insurance. Another clinic can be a different one. If one clinic is offering certain services and the other one doesn't, but this patient needs that, say this woman is pregnant and she needs this for her and her baby, I have to make sure that insurance gets switched. There's barriers. My goal is to one day hopefully have a place where all these programs are like in one building where you can go like, no, you don't qualify here because you're loaded, so go over there. Or no, you're straight, you go over here. It's hard to go somewhere. It's hard. You just don't know where to go. If there was just one place where an addict can just go there while you're still fogged up and nobody wants to be a drug addict. Nobody wants to be there. But somehow we ended up there. I have a disease and I wasn't born with it, but I know I'm going to die with it. And I'm going to have it for the rest of my life. And I've learned that I struggle with depression, anxiety, and anger. And that's mental health. That's probably why I was using all this time. I went to a therapist and I asked him, did I screw myself up with these drugs or was I born like that? He goes, Tommy, it doesn't matter. Who are you today? Who are you today? I'm someone that spent 30 years of my life using drugs, and I have the last 20 years helping people get off of drugs, and I'm going to continue doing that. Thank you so much.
Thank you, Tommy. Chair, I'll pass it back to you, and I think we have time for some questions and discussion now before we break for lunch.
Yes, thank you. Well, first, I want to thank all the panelists for sharing your knowledge, expertise, and just the wealth of information. So I want to just bring it back to fellow commissioners for questions, comments. Please, Commissioner Bunch.
I want to thank everyone. I learned so much today, and I'm actually embarrassed that I didn't know a lot of it, given that I'm in this field. I love this idea of meeting people where you're at or where they're at, and we hear it all the time in therapy, but I don't feel like clinicians think about it in terms of substance abuse. And I know personally, just from a recent experience with a family member who's in the past couple of weeks is going through substance abuse issues, and I was like, well, no, you have to stop everything. And I just, how little I know is appalling. One of the questions I had for you, Dr. Tsai, is your first slide, you had something about mental health and substance abuse not being under the same system. Can you clarify that?
Yeah, I was just talking about the Medi-Cal system. Because in California, you've probably heard the term kind of carved out, and that just refers to the fact that there's drug Medi-Cal separate from specialty mental health, separate from kind of fee-for-service Medi-Cal over physical health. So that.
Do you think that means that mental health is treating substance abuse in a really different way than like you guys are?
No, so there is some substance use treatment happening in especially mental health systems, but not as much as I think I've had conversations, for example, with our sister department about expanding their SUD capabilities within the specialty mental health system. But because of the carve-out system, and essentially it's the drug Medi-Cal system focused on substance use treatment, the specialty mental health system focused on mental health treatment. I think that there are opportunities, for example, under CalAIM with the behavioral health administrative integration to try to achieve more on-the-ground care integration, behavioral health care integration, where clients who have co-occurring mental health and substance use, which are a lot of clients, right, that we serve, can materially access all of the needed services at once versus being told to sequentially access services, which is kind of the suboptimal and traditional way in which people with co-occurring conditions are approached.
I can give an example of that. So if you are in my emergency department and you are on buprenorphine and you are also suicidal and need to go to or meet criteria for an inpatient hospitalization, you can either go to the inpatient hospitalization or continue buprenorphine, because they won't continue the buprenorphine at the inpatient psych hospital because I'm not sure, but they often feel like they're not licensed to continue an opioid treatment. And so this happens over and over where a lot of patients we will treat them in the emergency department because going to that hospital means you have to stop your medications.
I can also add with people experiencing schizophrenia or active psychosis, they're often told by the mental health community that they have to stop using stimulants like cocaine or like methamphetamines before starting antipsychotics. And it's been a real challenge to just say, we need to start antipsychotics now. It will help both of these issues. I'm not sure if your psychosis is due to your stimulant use pattern or because you have other mental health issues. But either way, we need to start treatment now and follow use, over time. So it's very rare and hard to find somebody who feels confident in saying that message, even though that's the standard of care.
We want to have a firm diagnosis of do you have organic psychosis or is this a stimulant-induced psychosis? And the person who's experiencing it, they don't care, right? They just want help. And we have this siloed system of if you have organic psychosis, you go over here. If you have meth-induced psychosis, you go over here. But that person, they really just want help and they are not in a place to sort out all of this. And so our system really is designed to push people out.
Thank you. I see a comment. Commissioner Robinson online, please.
Yes, thank you, Madam Chair. Fascinating presentation. Learned a lot today. Really proud of what California is doing. And as someone who practiced many years ago, it's great to see where the science is taking us. I would just love to hear some comments about what we're doing to drive access for communities of color, marginalized groups, and particularly maybe even tailor comments a little bit around how we're providing access to older Americans that we know are starting to use medications at a higher rate than previously. So love to hear more about what we're doing to improve access to marginalized communities.
One of the things that help us in that way is employing people like Tommy. So we work with peer educators who have lived experience, who can really broker that cultural knowledge and that community capital and ensure that they're speaking correct language, making the right connections with people so that the credible messenger is that person who's in the community, and I'm supporting them in designing a health plan that works for them. So I think that's very important. In terms of older Americans, my bias, I work in hospitals, so I often see my patients are, 40s, 50s, 60s with end organ damage, usually because of their substance use disorder. So recognizing that, yes, you have heart failure, you have kidney failure, you have liver failure, and also you have substance use disorder, and we can treat all of these in this place and in this time. That's how our strategy has been. I'm sure there's lots of other good strategies too.
Yeah.
Go ahead.
I can, part of the work that we do is around media campaigns. For example, methamphetamine, the opioid crisis, fentanyl, we just released recently. And so for those campaigns, we are very strategic in terms of where those billboards, radio ads, social media messaging, how we're messaging to specific target audiences. The other thing I would lift up is similar to what Dr. Trotsky had mentioned in terms of workforce. We have a tuition incentive program pilot where, sorry, it's no longer a pilot, where we provide financial assistance to people who are interested in becoming substance use counselors, but don't have the financial means in order to pursue the coursework necessary to go through the registration and certification process. And part of that tuition incentive award does consider the backgrounds of individuals awarded to ensure that the workforce that we are facilitating matches the clients that they're serving.
And this is,
I actually just wanted to highlight that question because all of the work, particularly for substance use, needs to be grounded in equity. And we have not talked about the history of stigma, criminalization, particularly for our communities of color. And that underlies the entire treatment system that we have for substance use disorders. So I just wanted to say and to recognize we have a long history of providing different, highly stigmatized care, some of it just the criminal justice system, for people of color. And then if you look at where we're providing treatment, even today, and you look at difference in treatment access by zip code, primarily in lower income communities of color, that is where you will find methadone clinics. You will find buprenorphine access in higher income zip codes. And so today there's a disparity in terms of where we locate clinics and treatment access, but also we can't move forward until we recognize that long-standing history of criminalization and stigmatization in terms of how we address substance use disorders. So appreciate the question.
Thank you.
this is
I just have
Tyler's.
to say, my job is to find a place for somebody. It doesn't matter who you are. It doesn't matter if you're 12 years old or my oldest patient was 80-something years old. She didn't even speak English. She was from Vietnam. She got addicted to opium up there, and we got her on buprenorphine. But there isn't any places. There isn't any inpatient, especially if you're starting with medical issues. No one's going to take you. Rehabs are set up for people that are going to get their lives back, like myself, get back in the workforce and stuff. If you got some medical issues, that's primary, and then your addiction would be secondary. But that's where we come in and motivate the patient. Even now, people like myself that I know that are still alive are now having medical issues and going into in-home support services on methadone. But you have to go to the methadone clinic every morning to get your dose. But there's state laws where you can't prescribe it like you can buprenorphine, right? So that's a big problem. But it's complicated. Addiction is complicated, and there's a lot to it. I've learned so much, and we got the families to deal with. We got the mothers, the grandmothers to deal with. They don't know what to do. It just goes on and on and on and on. But that's why it's so important to have programs and know your programs and not be able to send someone of color to another place in town where he's not going to feel comfortable, to put that person in a place where he's going to feel comfortable, right? If such a place exists. Usually when someone has medical issues and is getting older, like myself, and is an addict, you're going to develop a lot of mental health issues. You stay homeless long enough, you're going to develop mental health issues and physical issues, guarantee you. There's going to be something going on.
Thank you, Tommy. I see Commissioner Brown. Let me just ask Commissioner Gordon. Commissioner Gordon, I don't know if you had your hand up, and if not, then I'm going to go ahead and move on, sir.
Oh, no, move on,
So
please.
Commissioner Brown, please, and then, yes, he did. Commissioner Brown, please.
Thank you, Chair. First of all, I want to thank all of you. You did an outstanding job. You're a great panel. I think you should take this show on the road. There's a lot of people that need to hear the message that you have. Lots of people both in and out of the system, those who control the purse strings for a lot of things. I salute your positive attitude and your obvious passion for what it is that you are all doing. So thank you for that. And I know at times it's got to be very overwhelming. You know, the LA County scope of need, the UC Davis, all of it is, you know, you're at the point of the spear. You're dealing with very, very significant numbers of people who have substance use disorder and many times co-occurring mental illness. And it's a tough field. It's a tough job. And I really, really appreciate all that you do. You said some very profound things today between you. Things like, you know, we're getting numb. People are getting numb to the number of people that are dying of overdose. As you so rightly pointed out, preventative deaths Some have pointed out that, if you equated the number of people that die to the number of people on an airplane, it's like we're having an airplane crash every day. And if we really had an airplane crashing every day, there'd be task forces mobilized, aviation experts. Everybody would be, thoroughly behind this effort. But there's just too much of an attitude, I think, that, oh, well, doesn't affect me, or doesn't affect my family, or this isn't in my sphere. And it's terribly sad, but it's just one of those things. Those people are using drugs, or those people are mentally ill. And the reality is, there is, I think, as you point out, so many things that can be done to save lives and to revitalize lives if the people receive the proper treatment. And I think that you've hit the nail right on the head. To do that, you have to take the care to where it's needed. You have to go meet people who are, by nature, perhaps resistant to service, but not completely unreachable. And to do that, you have to go onto the streets, you have to go under the bridges, you have to go, into the field, you have to work at night, you have to work on weekends. And one of the biggest problems that I think I see is that our traditional systems, both in mental health and in substance use treatment, are all based on Monday through Friday, 8 to 5 kinds of jobs. And they're based on giving people, appointments to come and go get treatment. And as you, Dr. Mullen, so rightly pointed out, these are people that don't have, they don't have transportation, they don't have cell phones, they don't have a whole lot of experience with responsibility in many cases, and it's very difficult. But my question, I guess, to you is, how do we recruit? Where do you think the people are? We the system, and I would say law enforcement, as well as the physical and mental health services, have to throw our recruitment nets in different ponds, because we're not getting the people that are wanting to work those weekends and nights and holidays and everything else. Do you have any thoughts or ideas on how we should change our effort to try to get people to seek this line of work and to continue in it?
Yeah, I can start off, and I think others will have thoughts too. Workforce is a really, really big challenge right now across the board. I think that the recent peer specialist benefit through Medi-Cal is one option for us to sustainably fund a workforce with lived experience who hopefully will be more open to provide the varied services that I think many of us have talked about as needing to better address needs in the community. I also think that having kind of creative ways to support workforce recruitment, whether it's through cost sharing, I mentioned, tuition incentives, bonuses. I know that a lot of counties are offering those in order to try to increase recruitment numbers with some positive outcomes. I think that there's always going to be a workforce shortage, but another approach that we perhaps haven't talked so much about, but isn't immediately available, is really looking upstream to engaging our future workforce. I think that that's something that we can be sowing some seeds to really get us where we need to be in the future. I also think there's a lot of room for us to work with our current workforce now, our current physicians, our current nurses, social workers, to get them practicing with more integrated mindsets. I think that the default right now is for people to think, okay, that's a substance use issue, let's refer them somewhere. And I think that that's something that we as a system, if we're ever going to achieve behavioral health integration, will need to break.
I keep going back to where I work with the mental health. I had 50 patients, and I'd make sure, and when Dr. Mullen, I'll never forget that she told me, we don't know what to do. The people keep coming back. And my mind is, I'm going to do whatever I can to keep them out of the hospital, whatever I can. I think that first year, 80% of the people I've seen didn't come back. It wasn't because they all got sober and clean. Some of them did, but they didn't know where to go. And I would take my time, one person at a time, to make sure they got the help they wanted to get to. So my next idea, and I've been sharing with Dr. Mullen, was that peer navigators are now coming up. I don't know if you heard of them. People with lived experience like myself, people that they don't care if it's Saturday or Sunday, they'll work because they want to give back. They're not afraid of walking up, seeing a needle on the ground. They're not afraid of seeing somebody OD. We've been there, we've seen that. I shared with Dr. Mullen before this Narcan, when I seen somebody OD when I was younger. I didn't know what to do. I knew they died, so I just hit them in the chest, came back to life. Another guy had to kick him to wake him up. But it was just like someone that's not afraid to go out there. I've been to camps. I go to camps. I go out there. When I'm feeling bad and I'm feeling like I'm not doing a whole lot, I go and visit there. That's where I feel more comfortable. So that's one avenue. That's one. For that 20% that can't keep coming back, they need that help. They're not mentally there. They can't. You can give them a resource. They're just going to drop in and just keep walking. They won't even make it to the pharmacy to get their medications. They need that extra help. And I think peer navigators, they don't make a whole lot of money, but they're not in it to make a whole lot of money. They're in it to give back and help.
I would say we love peer navigators. Peer navigators are siloed off. Again, you have to be a specialty mental health or a specialty drug treatment in order to access peer navigators. There are some new benefits around like community health workers where you can bring someone with that type of experience into a primary care clinic. But if we're going to get there to the point where people have access to treatment, it has to be integrated into all aspects of care. And I just don't accept the fact that it can't happen because I've seen emergency physicians prescribing buprenorphine. So when we hear, oh, primary care can't do it, I think we just have not yet given them the tools and the resources to do it because I saw that adoption in emergency departments during the COVID-19 pandemic. And in terms of like, where do you cast your net to find patients? The emergency department, the criminal justice system, and the streets. It's not, I mean, we know where the patients are. We just need to go and provide treatment there in the emergency department, criminal justice system, unfortunately, and the streets. And so this is our thought is, I know where the people are. I know how to get them treatment. And so part of it is it just kills me that we're not doing it.
Thinking about like EMS services and fire departments and police that are available 24/7 in addition to the emergency rooms. So, our EMS in some of our counties are leaving behind naloxone, starting buprenorphine, because they're seeing those people overdose at 2 a.m. and then who are afraid to go to the emergency room. When we can address people in the emergency room, that's great. There's a large number of people that don't even make it that far. And if we can empower those helping professionals who are already up and awake and involved in our communities 24/7, those are the people that need the support in the real time, whether it's a phone a friend availability or some standing orders or some other kinds of ways to give them the tools to start treatment in that moment.
So, so what I'm hearing is, the continued siloing, we really need to integrate the primary health, the mental health, and the SUD, right? There's a way to do it. Why aren't we doing it? And we had Tyler on the call, and I don't see him because I would love to ask the state. Let's get there. So at this time, though, I do want to follow. We have Dave Gordon, and then I see Commissioner Danovich, and then Commissioner Mitchell, and then Commissioner Carnevale to make statements. So let me start with Commissioner Gordon, please, online, if you could.
Yeah, thank you, Chair, and I want to thank the panel. It was an excellent set of presentations, and to Dr. Mullen's point, I work in the school system as a superintendent, and we're trying the Navigator system with some of the SB HIP reforms, which have been very, very promising. And I will say to you that I struggled with a substance abuse disorder. And if not for my family being able to navigate the system in the ways that Dr. Mullen has spoken about, I would not be alive today. Trust me, I would not be alive. But that's what every person in the situation I was in really needs. And the system just has got to change and look at someone like Dr. Mullen should have the authority to call upon a trained navigator with lived experience, because the first 2 or 3 things that someone wants to try to help you may not work. But if you're out there just on your own, coming from appointment to appointment to appointment, you're not going to make it. You're not going to survive all of that. You have to have an advocate or a navigator or somebody to work with you. So I would say, as we move forward with trying to make the system more accessible and more helpful to the people we've talked about today, let's think outside the box, and let's not be caught up in the system the way it is. It needs to be different. So thank you, and thank you, presenters, and thank you. Your work is heroic.
Thank you, Commissioner Gordon. Commissioner Ganovich, please.
Yeah, so my question was going to be directed to Tyler Sadwick. If he's not on, perhaps I'll direct it to Gary Tsai. And it relates to a stakeholder that we don't have represented. And first, I would echo Commissioner Brown's just commendation for what an outstanding panel this is and the roadshow idea. I think I live in this space and I'm still moved to hear how incredibly each of you articulate the urgency and the importance and the impact. Dr. Mullen, in the example that you gave of the person that you took care of, right, you initiated them into care, and then you couldn't connect them into care, and you had to go beyond your role as an emergency physician to manage somebody on an ambulatory basis. And I think that speaks to who is not around the panel list, which is the programs, the specialty substance use disorder programs, who are supposed to be able and ready to accept people who've been started on treatment and continue that treatment, and manage things that come together with treatment, like PTSD or like a certain level of psychotic disorders or depression that are so comorbid. And that's a part of the system that has a lot of the ingredients that are necessary to deliver improved care. And now, Tyler Sadwick spoke about standards that the state has adopted and requirements for what it means to deliver each of those care. And yet, the way things work in our system, monies from the state flow down to the counties. Dr. Tsai's group subcontracts with providers and then has to try to support the program's ability to actually meet standards of care that require them to address these conditions in an integrated way. The question is, how do we help? I mean, until we help those programs provide better care, we're going to continue to have people cycling through the system, getting initiated over and over again and falling through cracks. How do we support that system to be able to provide higher levels of care consistent with the standards, to leverage all these new funding streams that are supposed to incentivize more holistic and integrated care and help us get out of the cycle?
Yeah, I think that's a great question. And I think that what we had talked about earlier in terms of the split of funding in Medi-Cal for especially mental health versus drug Medi-Cal is significant, because it highlights why a lot of agencies are struggling with some of the more state-of-the-art standards that are being set now. For example, through the American Society of Addiction Medicine, where MAT is elevated, medications for addiction treatment are elevated more. Even currently, there are regulations in residential substance use settings that consider them non-medical, right? And so that's something I've spoken with Tyler about, and I know that there's interest in kind of figuring out how we can ensure that all health facilities, including residential substance use facilities, are considered medical, so that we can offer things like MAT more readily. And so I think that one of the most important things is that we invest in the special SUD system to be able to meet the expectations that we're all setting for them. You know, I think that whenever there's been funding opportunities, for example, Prop 64, right? The investment on the specialty systems has oftentimes been overlooked. And I understand the frustrations, for example, with Dr. Mullen in trying to refer in specialty systems and having challenges. And to me, the answer isn't, let's figure out how to bypass that. The answer is, let's figure out how we invest in that to strengthen the system. Because the reality is that, you know, from where I sit, we will not achieve on-the-ground behavioral health care integration unless we invest in the SUD system, because the SUD system is an essential arm of behavioral health. Otherwise, we're just talking about mental health. And I'm a psychiatrist, so I know I value mental health. But you know, having worked on the special SUD side, the dearth of resources, the dearth of attention, the lack of focus on priorities around substance use, I see that every day. And that's one of the reasons why I appreciate this commission focusing time and energy on this topic, because you know, we're in an emergency situation and we need to be acting as such. And so I think that investing resources in the especially SUD system to get it up to where it needs to be, workforce is something that we have to always be focused on in terms of, you know, training standards. There have been recent efforts to elevate SUD counselor training standards. SUD counselors represent 80% plus of the workforce in the special SUD system in LA. I think that is reflective of other counties as well. And I think I've talked to some of the commissioners yesterday about this. When we talk about behavioral health workforce, in the past, a lot of behavioral health workforce initiatives were focused on licensed clinicians. And while that's needed, that bypasses, as I mentioned, 80% of the workforce of special SUD systems. And so that's just something that we have to keep in mind. I know that more recently, HCI has made some progress in focusing behavioral health workforce initiatives that include SUD counselors. And I think that paying specific attention to that will be really, really important. There's a lot to that question, Commissioner Denovich, and happy to talk more.
I just want to say it's a great question. And this is one of the things that makes me very frustrated, is that we continue to fund residential treatment facilities that don't incorporate medications. We know that medications work. And so why, as a state, do we continue to fund programs that don't insist on offering medications? To me, that would be like allowing there to be a treatment program for diabetes and hypertension that focused only on diet, but didn't offer someone insulin. It does not make sense that we continue to allow that to happen. And to the other point, the thing that, from my perspective as an emergency physician, when we look at standards for clinics, what you then see is you only see the people who are already in that system, and you are looking at how well they're providing treatment to the people in the system, but entirely missing the bulk of the population that is outside of the system. So we need to think about both of those things. How do we do a better job of taking care of people in the system, but also how do we reach the people who are not there and make sure that they can get into the system? And so those are two things that are sometimes in tension with each other. And I just want to make sure that we don't forget about the people that aren't even getting in the door.
Thank you. Commissioner Mitchell and then Commissioner Carnevale.
I think most of it's been said, but the presentation, thank you. The presentation was absolutely beautiful. It restores my hope in this area. There's so much stigma with SUD, and I think that's lots of the problem, much of the problem. So, you know, to the sheriff's question regarding how do we deal with this workforce issue, I just think so much of it, and I just want to put it on the record, it just has to do with education and reducing the stigma. We've had reduction, you know, we've had stigma campaigns to reduce stigma, but a lot of it is, as Mr. Trevino said, it's just people caring, people who have been who have the lived experience and wanting to be on the ground, whether it's at midnight, whether it's at 2 a.m., whether it's whenever, they want to give back. So it's that workforce that's out there, at Sylvia yesterday, in the trenches, not unafraid to go up to someone who looks horribly frightening and say, hey, what do you need? Have a conversation, see that person. That's the workforce that the net needs to be spread to, because those are the people, Dr. Mouton, who are going to bring those patients into the clinic. The question, hey, do you need help? Are you going to be here when I come back? Because I have a bed. I know where you can go. But there's so much ignorance, fear, bias of the very people that we are employed to serve. And no one wants to talk about that bias. It's that quiet, we talk about our clients, we talk about them. And so we must educate our workforce to why we do what we do and the history that comes with that practice. Because the history just didn't happen. We practice a certain way because those are some old practices that came to this country as we colonized it. And so those practices have not gone away. We just need to continue to educate and cast that net to those individuals who really care about people. And if you're on the high end of the spectrum in terms of income, that's great. There are tons of people at the bottom of the ladder who will do anything they can to bring that client in, whether it's 2, 3, 4, 5 in the morning. So thank you for just mentioning the disparity. The methadone clinic in the hood versus the buprenorphine in Beverly Hills. Those are real disparities that no one really wants to address. So it comes down to education, educating this field. So those are just my comments. Thank you.
I just want to say 100% agree with you. And I wanted to bring up the point of Tommy changed my entire hospital just by being there, by modeling that destigmatized and behavior, and by showing us all that substance use is treatable. And so we all learned, hey, there's something we can do. And he changed not just the emergency department, but the whole hospital. And this is actually why California Bridge, the primary focus of California Bridge was to fund substance use navigators in emergency departments. We did training for the doctors, but the primary focus and my goal was to put a Tommy in every emergency department in the state of California. And I can't say enough about just having him there made all the difference in the world in how we practice and how we approach people. And you're 100% right about the disparities in how we treat people. And this is a whole topic, and I apologize I'm going over town, but this is just something that I believe in so deeply, is if you take that history of criminalization and look at how we provide treatment, and a lot of times we have these paternalistic treatment models that bring that ethos of punishment and criminalization to our treatment space that alienates people and exacerbates disparities in how people are treated and receive that treatment because of that treatment ethos that has its roots in criminalization. So I appreciate you for bringing it up, and we could talk about it all day.
Thank you. I'm going to go with Commissioner Carnevale, please.
Thank you, Madam Chair. I don't know about anybody else, but I'm agitated. I'm thinking of an old movie. I don't remember the name, where the guy sticks his head out the window and just says, I'm mad as hell and I can't take it anymore. I mean, how many times are we going to listen to frickin' broken systems that we're just living with? So we're sitting here, and I'm going to come to a specific recommendation, but I'm going to rant and rave for a minute. I mean, we've got the Mental Health Commission here, we've got HHS here, we have had a Senate representative here, we have all the government representatives here, and we're treating this broken system like we're the victim and there's nothing we can do about it. If we can't do something about it, then who is? How about if we commit to the buck stopping here and we figure out how to fix this system in this case, this one time? You know, I just think there were so many places that were broken yesterday. I wouldn't even know where to start. I just remember one example. Somebody said, you know, people get let out of incarceration and it takes them 30 to 60 days before they can get the paperwork to get their health care, I guess. Is like, in what planet does that make sense? Who made these rules? Who's decided this was a good idea? There's just no way that this decision makes sense from a people place, from a cost place, from a system place. It doesn't make sense. So I know I'm naive. I don't work in the system. There's 100 reasons why it's built this way. But how about if we start dissecting it? So I'm the business guy here, and you know, I'm usually the guy who's thinking big picture and strategy, but I'm going to pick up the other end of the stick here, because to me, this is a real operational problem. I mean, Dr. Sy, I appreciate you growing the program through, you know, innovative financing, which is great, and you said the right thing, which is we have to stop band-aiding this. So business solves this problem by reversing the whole thing. We have a system that's structured and we're pretending it's fixed, and then we're hiring navigators to help the clients, you know, work within our system. We do the opposite in business. We actually dissect the customer experiences and we change our systems to meet the customer. And we do it to sell them cheeseburgers and Christmas ornaments and lawnmowers. So, you know, maybe we might want to do it around something important like healthcare. So I'm going to suggest maybe this has already been done. If it's already been done, then great, let's elevate it and do something about it. But if not, I would recommend, since we're in the business of innovation, one of the places we should spend our innovative dollars is let's go outside the healthcare system. Let's hire the people that do this for business. You go to the Stanford D School, you go to IDEO, you go to people who do human-centered, design-centered thinking, and they will architect the entire journey and identify all the places that's broken. And let's identify all the systems and the people and everybody that make these decisions, and let's figure out what we have to change to fix the system, and let's go change it. I mean, it's a simple concept. It's very hard to do,
So
but it works in business.
Thank you, Commissioner Carnevale.
Yeah.
So we have Tyler back online, and Tyler, I hope you've been listening to what Commissioner Carnevale said, and just, we've had questions, knowing, you know, it seems that as it stands now, the system is essentially just been designed to fail. And so everything's siloed from our primary health to mental health and SUD. And so what is the plan for the state to really align so that we're able to address this effectively? And it's not so siloed, and we're not letting our citizens, you know, fall through the cracks. And so if you could just share with us your thoughts around that.
Sure,
And
thank
thanks
you.
for coming back on, Tyler. Appreciate it.
Yeah, absolutely. Just want to confirm you can hear me.
We can.
Excellent. Thank you. Thank you, Commissioner, for the question. Unfortunately, I think as the commission knows well, with mental health, we have a fragmented service delivery system, and I think that is compounded for substance use disorder in particular. I think it's the result of, you know, sort of decades of policy choices, decades of underfunding, decades of neglect in research and the medical establishment in treating substance use disorder as a healthcare condition. And in fact, you know, across the country, you know, counties were sort of left with the responsibility for it. And in the absence of science and medicine and sufficient reimbursement, providers have sort of cobbled together, you know, practices that worked for them, which are often rooted in 12-step programs and mutual aid societies. So I think it's just helpful to think about where we're coming from. Currently, under the CalAIM initiative, the department is seeking to implement what we call administrative integration. Gary touched on this in his presentation. For behavioral health services in Medi-Cal, currently counties operate two separate systems. Some counties have come closer to achieving progress on the spectrum of integration, but historically counties have operated mental health plans where they deliver specialty mental health services, and separate from that, they deliver drug Medi-Cal services, or now most deliver drug Medi-Cal organized delivery system services. Historically, those were often two separate agencies, even at the county level, similar to how previously the California Alcohol and Drug Programs was a separate agency from the Department of Mental Health. Approximately a decade ago, Department of Mental Health and ADP moved into DHCS. Counties, just at the administrative level are integrating, so it's one behavioral health agency. But right now, state laws, state regulations, contracts that counties hold with the department are separate for mental health and for substance use disorder. And of course, physical health care, medical benefits are an entirely separate delivery system in Medi-Cal. Those are primarily covered through risk-based managed care plans. Under realignment, which is in our state's constitution, counties have the obligation and the responsibility for providing behavioral health care. Under CalAIM administrative integration, the department is seeking to integrate mental health and substance use disorder into a combined integrated behavioral health delivery system. I want to be clear, that would achieve administrative integration so that we seek to align our laws, our regulations, our contracting, our policies for administrative purposes. What that does not do is full clinical integration. So it does not mean it is achieving 100% patient-centered care where they can walk into one facility and have all of their needs met. That is the goal. We do need to get there. And I think administrative integration is the first step in that path. I hope that was helpful to the comments.
Can I make a comment? Commissioner,
I just have a question. So when you say that's the goal, timeline, is that a human-centered approach? I mean, because what we saw, we're talking lives today. We're talking, hourly. So, and knowing, I mean, it sounds like we already know what we need to do, and what Commissioner Carnevale is saying, now, we need to do now. So tell me what that looks like. And then we're talking about equity issues. We're talking about, there's a very certain population, and that population, we know what that population looks like. So how quickly, what does that look like?
Yeah, I mean, I think there's, a lot of opportunity and a lot of responsibility in almost every part of the healthcare system. I think, under the state opioid response grant funding that I walked through, we've been supporting federally qualified health centers, primary care, physical care providers to be able to address addiction, to provide medications, buprenorphine. That's an example that they can do that, and it's a matter of clinical practice transformation, change management, building will at the provider organization level, having leadership support, having clinical training to do it. I think same on the substance use disorder side, on the mental health side, being able to provide clinically integrated care is often a matter of providing resources to support the sustainability and the practice change at the organizational level. So I think this is an area that the entire nation is struggling with, and I'm happy to continue conversations about how we can support providers to integrate care delivery.
Thank you.
Can I ask one follow-up to that?
Please, Commissioner Danovich.
Thank you, Tyler, and thank you for your overview of the system in California. There is a lot that DHCS has done to set the table and in terms of adopting standards and aligning payment to facilitate where we need to go. I think the exasperation that you hear is that we all want to see this accelerated, and it's not clear how we can accelerate it. Today, we're talking about an initiative where we have a small pot of money, but $20 million that we can potentially place into accelerating some part of this. And interested in your thoughts, understanding both what the opportunity is and the enormous gaps between the high-level standards and plans and payment reform that's been established at the state level, and then the barriers when you come all the way down to the programs that are contracted to deliver the services that won't integrate the change, that haven't yet raised their level of care, that are not certified, that create all the barriers we then see at the person level. So what are your thoughts about what some of the most compelling addressable opportunities are that would accelerate that reform?
Sure. Thank you, Commissioner. I think that, the site visits that that members participated on yesterday, showed, I think, what can happen when there is will and there are resources to meet people where they are. And I think if we are to sort of save lives and address the individuals facing the greatest risk and the greatest inequities, providing low barrier care, including through street medicine or outpatient clinics that offer, easy access, opportunities for people to receive evidence-based care, including medications, immediately on the front end, while a lot of the administrative challenges that are inherent to the health insurance model in the United States are sort of deprioritized and really prioritizing patients first. So I think it's that low barrier care approach, that model, that philosophy that pockets across California have been able to achieve, like some of my co-panelists today. That I think is a really important opportunity in terms of immediate small scale support.
Because we heard a lot about the impact of these programs in leading to initiation, but there's a lot less data on continuation. And so that the focus of the question really is what happens after somebody's initiated when somebody needs care within the specialty substance use system, what we can do to accelerate and improve care within that.
That's a fantastic question. I think that we are beginning to facilitate dialogue and resources for SUD providers in California to help sort of further our understanding and have solutions to answer that question. How do we lower the threshold to care? How do we meet people who aren't quite ready? I think Gary touched on this in his remarks. The department is organizing harm reduction workshop summits where we're convening stakeholders across the state to talk about exactly that question. How do we get someone in the door, and how do we keep them in the door? How do we keep them in treatment? How do we lower the bar so that our treatment models are not designed for people who are fully motivated, fully committed, perfect patients, but rather the majority of people suffering and struggling from substance use disorder who need help, who want help, and who need the system to evolve. We're actually contracting with the American Society of Addiction Medicine to develop clinical guidelines. I think they're called clinical considerations to address this precise question. How do we develop policies and procedures that embrace and embody and implement the philosophies of patient-centered care within a chronic disease management framework and really put harm reduction practices into work at the SUD treatment setting? So these are just excellent questions, and it's something that I'm beginning to work with stakeholders and work with my department on.
Madam Chair, I would just reiterate my point. I appreciate system integration is a great objective. We also heard, I think, from Dr. Moulin that a high percentage of the issues are outside the immediate system. And I think a big issue here is we do not have a clear definition of the problem. And until we have that, we're not designing all of the right solutions to get to outcomes that are going to be different. we have failed outcomes here. And so, again, I would take a patient-centered, invest in a design process that we can clearly elevate, identify the frustrations and the problems, and begin to elevate solutions from the patient side of this equation while we're trying to move the system around.
Thank you, Commissioner Carnevale. And I would say, I hear kind of the steps that you mentioned, Tyler, start with the administrative integration, which is not clinical integration. And I would just say, I want to start with the people on the street first, and then backflow to the administrative and the clinical. That's what I want to see as we're stepping around and stepping over. And I'm seeing, people who are suffering, and yet they still, as they see us walking by, wherever they are in their suffering and their addiction, and they still have the presence of mind to, fix their here. It's still that human dignity. And that's what I'm seeing. And so when I hear language like, the administrative integration, I don't hear the people first. That's where I'm struggling with it. And I know it's a process, Tyler, and I want the conversations to keep happening, and I know we're working towards it. So I just needed to say that out loud. And with that, I'm going to pass it over to Commissioner Bench. I think you had a question, so please.
Yes, thank you. I had a follow-up question, Tyler. You mentioned several times the need for low barrier care, and I think I'm missing what's preventing that. What is it that's preventing the low barrier care that's needed?
Yeah, that's a great question. I think it's a combination of sort of initial infrastructure and support. It's hard to create something out of nothing. I think it's a matter of sort of clinical, changing clinical practice and the sort of, policies and procedures in the clinical setting. And then to some extent, funding, I think is needed because, I think as Dr. Mullen highlighted, if someone does not have health insurance, or if someone's health insurance, their eligibility is not active, or for whatever reasons, we all know there are administrative challenges to reimbursement in a medical insurance model. Sometimes funding is needed for that as well. And there are funding streams available, grant funding, other dedicated funding outside of Medi-Cal, outside of insurance, but that can be a challenge as well. So I think it's a combination of clinical, administrative, and financial things that need to be tackled.
Commissioner Gordon, please.
Thank you. Yeah, I think I heard Dr. Mullen speak to the fact that once the emergency was over, the person was rescued and stabilized, then there was the period of adaptation to treatment, which had to be appropriate treatment. And what would it take, Dr. Mullen, to make sure that the treatment post-rescue was completely appropriate? Because it sounds like people are getting sent off to whatever place is available or services available. But what would it take to pilot an appropriate way of doing that, a more effective way of doing that?
Great question. And I think about this low threshold clinic piece, I think is really the key, where you could locate clinics in areas of high need that could be walk-in, welcoming, in order for people to continue buprenorphine that was started in the emergency department or on the streets, or people could come in and access treatment primarily. And in that setting, which would ideally be welcoming with peer supports, those clinics could stabilize people. Some could go back into the dual diagnosis clinic. Some could ideally go back to primary care, where you could get diabetes treatment, HIV treatment, depression. But to have a place where anyone can enter the system and not be struggled with your insurance. The beautiful thing about the emergency department and why our model has worked is because it is the only place where healthcare is a right. you show up in the emergency department in whatever state with no ID, with no immigration status, and healthcare is a right. And if we brought that ethos to an outpatient clinic where someone could come back, where they could receive treatment, and maybe they come to that clinic for a year, 2 years, a month, just one time before they transfer out to a long-term solution, I think that answer would fill in this gap and allow people to access treatment when they need it, how they need it on their own terms, something that allowed walk-ins. There is a model, there's the Highland Bridge Clinic, which is a low threshold access clinic. And then my colleague, Dr. Trotsky, sir, also has that low threshold model, but it's really, the question is like, what is the barrier? The barrier is the way that we finance healthcare, right? Because we finance healthcare based on these different funding streams, but it's the person who needs the care. And so we know the barrier is like the way that we finance healthcare in this country. And I mean, it's this sort of kind of corrupt capitalist system, and that's what we have. And it is not designed to work for people. And in this situation where people are really struggling and the disease process, I mean, this with mental illness, it's kind of the same. Your disease process makes it harder for you to overcome some of these barriers that we put in front of you. And so because of that, we have to overcompensate in our delivery system to make it easy for people. I often think, we make it hardest for the people to access service who have the hardest time getting there. We put more barriers in front of that patient population when we should strategically put less. So I would say invest in a network of low threshold access clinics that take advantage of a lot of the amazing changes that have been in place in CalAIM, but also allow people to walk in and take that healthcare is a right view that works so well in the emergency department.
Thank you. Thank you, Dr. Mullen, because I would just say that I think the financing part of it is really, if you don't solve this problem, you're going to spend money over and over and over again with more emergency treatment for the person until the person dies, and then they're off our books. But I don't know, maybe Steve Carnevale, maybe this is something we could try, the approach that Dr. Mullen suggests as a pilot with some of the money that we have available. Thank you.
Madam Chair, can I just briefly, I won't go into a lot of detail, but just last week when we were in New York at the end of our Brain Capital Summit, as part of the UN Science Summit, I was invited to the Danish embassy, and I heard a presentation on a public-private partnership that Denmark has between industry and their insurance providers and government and foundations, and they've all come together, and even the pharma companies have said they're willing to modify their profit objectives in order to pull together a system that serves more people. And I think, going after the financing end of this is absolutely something that should be done. And again, we can just live in the system and integrate it, or we can change the system. And I recommend we try to change it.
Thank you, Commissioner Carnevale.
So I echo everything you've been saying and also say it's both and, right? As we're rebuilding a system that makes these outcomes possible, we have to design these low barrier strategies. And you saw some of that yesterday. You saw, welcome, I'm so glad you're here. No matter what, I want you to have my phone number. Here it is. This is my direct line. Any barrier you have, we've worked really hard to help you overcome that. If something happens and you weren't able to pick up your meds, just come back. I put a refill in the pharmacy. You don't have insurance to pick up that med, that pharmacy has a spend down account, so you can just pick up that medication. You need somebody to go pick up that medication for you and bring it back to your tent, you have somebody doing that for you. So we just really lovingly thought through every single barrier one could possibly face after starting treatment in our hospital, in our ER. There's a hotline you can call. We will come and see you no matter what. We can do a video visit. You live in Lancaster? Okay, you have outside insurance. We have a community benefit hotline that you can also call. So it just is really having these dedicated reimagining of how we deliver healthcare so that it's extra, right? It's that concierge service for people in the most need. And, you know, often it's unfortunate the reverse, right? I have private Kaiser insurance and I have that concierge app on my phone. Like, we need that same level of attention and detail and caring to people who are the most unlikely to have that historically.
I appreciate that. So I want to thank you again for being here. And what I would like to do is have staff work closely with Commissioner Danovich and Commissioner Carnevale to really just, and with panel members as the experts, and of course with our peer community, to come up with some ideas of how we could move forward with this, where we could put that funding toward, and what a design or a pilot would look like. So if we can do that, we will move this conversation forward, or the planning forward. And this time I would like to, again, thank you for being here. We are going to have public comment. Since we have no other further conversation or questions from our commissioners, we'll move forward with public comment. So now is the time that members of the public may request to make a public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Mariani, are there any public comments? Please raise your hand now as the queue will be closing.
So we currently have 1 public comment in the room and then 4 online. In the room, we have Steve McNally.
Hi, my name's Steve McNally. I'm from Orange County. I'm on a behavioral health advisory board, like every county has one. LA Mental Health Commission, which I'm sure their people will be here, but they have a conflicting meeting. I speak as an individual. My background is mostly mental health, and but all these issues are all interconnected. You know, for me, people make a difference, and it's obvious from your panelists. They figure out how to make a difference, but we don't have a culture that is honest and presents problems as well as solutions. We're so focused on, as our guy the new head of CalOptima talks about, is the acrylic silos and worshiping them versus just fixing the problem. And some of the biggest solutions, like let's say for housing, would be existing housing to get reconnected people back in and reunified. So substance use, serious mental health, they're the most disconnected people. And yet we have to wonder why we have a system that doesn't embrace the simple solution. Any business knows that a receptionist knows more about their clientele or at the low level, but it's very difficult. I attend a lot of meetings, and it's very difficult to have anyone from who actually use the system to be included. And so for California, I say this a lot, almost at every meeting, but I'm going to say it for Gary's benefit because I didn't get a chance to see him and Ronnie and the Inland Empire guy at the Department of Healthcare Services. Those 4 counties, LA, Orange County, Riverside, San Bernardino, represent 45% of California, 1 TV market, 1 radio market, 2 newspaper groups, and that's counting the LA Times as a group. And that anything else that you do, that's just general market, not ethnic market. So there's a tremendous opportunity, suicide, opiates. So that's one thing I think we could do collectively. The other is culture. School, everyone can order Narcan. Almost anybody can order it. And we've been setting up a separate distribution for families because a lot of pharmacies don't carry it, or you get judgment. But you know who doesn't order it in bulk? Is police departments, schools. They order enough to have, and someone dies and is overdoses in front of you. But their culture isn't to just acknowledge the problem and to freely make sure that families are empowered to handle it. And the Hospital Navigator program is incredible. But I'm not sure how many families even know it exists outside of if you go there. And the goal is not to have to go there. So even even in my county, I can't tell you, whoops. Ah. I can't do two things at once. Ah. Did you enjoy that? Stop. Stop. All right, so I'll end that there, but the thing it is that people make a difference. And we have a lot of bureaucracy in our system, whether it's private or public. And you're focusing a lot on homeless, which is very important, but it's relatively small versus the whole piece of the pie. And I think CalAIM, we talk as if it's actually happening. It's very aspirational and terrific, but it's not actually happening in a lot of places in any kind of scale. So I would just ask us to be honest. And also, people need to hear honesty and it has to be okay. We're here and we don't want to be here. I want to be with those 4 people. Let's just collectively own how we got here, quit being so defensive, and just get someplace else. So thanks for letting me speak today.
Thank you.
Next, we have Richard. Your line is open.
Hello, Richard Geller from Santa Cruz, California. I want to thank the panelists for their expertise of what they shared. It's knowledgeable, it's facts, and what they stated is truly needed in our communities because our communities is not equitable to those populations that are not being served of access to care that they need. The other thing is the 5,000 peer workers that CalMESA has already invested with nowhere to go because the state agencies chose to not include peer workers in the CalAIM or the Modernization Act. And we will lose funding more than half if the bill gets passed with Proposition 1. That's a big if. This is why I'm upset with the commission that supported SB 326. You're devoting less funding for counties by diverting for other purposes and needs. Does not focus on the intent of the MHSA Act. We need people like Tommy who will do the work. I'm one of them. I have helped consumers, seniors, people with disability, unhoused community to navigate through the system, to provide the support while they're trying to recover, to provide the needs to get them out of homelessness. It can be done. Let's do in navigation centers by providing peers along with the medical community to support these individuals in their recovery. Let's partner with community health clinics. Each county has a community health clinic. Let's partner with them, with peer workers to help our vulnerable communities that's not being served, especially the unhoused community. Thank you.
Thank you.
Next, we have Laurel. Your line is open.
Good morning. This has been a really interesting morning. And I wanted to recall a story that our beloved Janet King of the Native American Healthcare Center in Oakland once told. She said that when their center opened, I think it's on International Boulevard in Oakland, there were what were called Indian bars all along that boulevard where Native Americans with addictions to alcohol spent a lot of time. Gradually, as the Native American Healthcare Center introduced its culturally community-defined evidence practices, there weren't customers anymore for those Indian bars. People were going to the Native American Healthcare Clinic to get care that wasn't, they may have included medications. I don't know that they didn't, but they definitely included culturally defined evidence-based practices. And so I would ask, in addition to considering a statewide network of clinics, as the speakers have suggested, that you also look hard at the CDEPs. for those that may be able to help with this current crisis that we're in. And remember Janet King. The second thing I just wanted to add, only because it was just mentioned, I happen to live in Sacramento County, and last year I went to probably 3 all-day conferences about opioids and/or peer support. And the opioid summits for Sacramento County and Placer County were held by federal law enforcement, local law enforcement, and there was a heavy presence of the Sacramento area school personnel, and probably Placer County too. Now, their emphasis wasn't on people living in the streets. Their emphasis was on high school students who are under stress and might try just once or twice. They think they might get help when they're stressed on exams, and they might try something and die because of the fentanyl laced into other medications that they can get online. They trained everybody in those conferences on how to use Narcan, and they handed it out to everybody walking out. Even I got that. So if a grandma from Muslim American Society Social Services Foundation in Remco can
Thank you,
get
Laurel. If you
Narcan
could
for
please wrap up your
free.
comment, your 3 minutes are up.
Okay, look at Sacramento County. Talk to you have the school commission lead there on your commission.
Thank you.
Next, we have Kim. Your line is open.
Great, thank you so much. I appreciate the panel and everything that was shared. I want to take a little bit of a different and very specific lens that I think Dr. Tsai had started to mention that is such a critical piece. So we work, my organization, the California Youth Advocacy Network, we work very closely with youth and young adults on social justice youth development to ensure that youth and young adults are at the forefront of changing the communities and environments that may lead to substance use behavior. And what we try to do is prevent it before it ever gets to a point of needing the SUDS treatment that you all are discussing today. But I want to note from a K-12 space, one of the biggest challenges that we have right now is that the systems where young people go to school, in fact, criminalize youth use, substance use and possession. We had legislation that would have prevented this, at least from a tobacco lens, and unfortunately it got stuck in committee. And so even if schools have intention of doing intervention, there might not be funding to do it, and the system in which they exist actually encourages suspension and detention for youth substance use, which is highly, highly problematic. And then I think we also need to look at that when we talk about treatment, we aren't getting down to the root causes of why young people are using. And this is where there's that intersection of mental health and substance use. So how do we collectively address this? This is something our team is actually looking at from a college perspective, because as Dr. Tsai had shared, and this is so relevant for young people, that many young people who use substances may not want help quitting or even believe that they have a disorder or an addiction that needs support in quitting. But if we change that lens and we integrate it within mental health, we'll be more successful. And so when we look at data from the national college surveys, we find that the majority of young people who experience a mental health condition are willing to get support and care for that condition. But if they use tobacco, marijuana, or alcohol, they will not get support. So how do we integrate these two streams so that if somebody is seeking medical care, they're screened for substance use and for mental health? If they're seeking care for the mental health, how are they also screened for substance use? So we really need to, again, break down the silos within public health. I work in tobacco, but every young person we work with that is using tobacco is either suffering from a mental health condition or at risk of using a cannabis product or currently using a cannabis product. We need to integrate it all. We need to have these conversations, and we need to be engaging young people to change these systems that are actually perpetuating the harm. Thank you so much for your time.
Thank you.
And then we have our last public comment, Stacy.
Good afternoon, Commissioners. Stacy Hiramoto with the RIMCO, the Racial and Ethnic Mental Health Disparities Coalition. Really want to thank the Commission for putting this panel on. I am really remembering Dr. David Pading, former commissioner. I think most of you know him. He would be so pleased that this panel was put on. And I want to thank the speakers, especially those that addressed disparities and communities that do not just go with the mainstream. So I'm just asking that if the commission does vote to allocate Mental Health Wellness Act funds for a program that special attention or language is inserted so that community defined evidence practices can be utilized and that underserved communities will be addressed also. Thank you again.
Thank you, Stacy. So with that, I want to thank again the panel for being here. And we are going to thank Commissioner Danovich to work with panel members, peers, and staff to design a proposal so that we can invest in a response to SUD needs. And we will bring that back in November. So I hope so. I hope so, Commissioner Danovich. Again, thank you, everyone. And with that, we are going to take a 30-minute lunch break. So we will return in 30 minutes. Thank you, everyone. please take a seat? Here we go. Okay. Welcome back, everyone. We are going to go ahead and get started. All set on Zoom? Perfect. Moving on to agenda item 8, the commission will consider approval of an innovation funding for the workforce recruitment and retention strategies project over 5 years. We will hear from Stephanie Hess, who is the MHSA coordinator for Alameda County Behavioral Health. Stephanie, if you are ready.
Hi, I'm ready.
Perfect.
Let me go ahead and share my screen. Share. All right. Here we go. All right. Thank you so much for having us today. We're excited to be here, and we're excited to talk a little bit more in detail about our workforce recruitment and retention strategies innovations proposal. I'm Stephanie Hess. I'm the Mental Health Services Act Programs Coordinator for Amador County Behavioral Health. And I also have my director here, Melissa Cranfill, who will be available to answer questions after we're done presenting as well. All right. So here's an overview of our workforce. We're calling this our workforce snapshot, as you could call it. And as we all know, recruitment and retention for the behavioral health workforce is a national, state, and local challenge. Although efforts are being made to address the workforce shortages, many of the initiatives fall short or do not include considerations for small and rural counties like Amador. Amador County Behavioral Health is a fully integrated system of care that provides outpatient mental health and substance use treatment. When we are fully staffed, we employ 25 full-time employees, 1 part-time employee, 2 extra help crisis workers, and we also supervise the behavioral health rehabilitation specialist, which is funded by Amador County Probation using AB 109 dollars. In addition to full-time outpatient behavioral health services, we are mandated to see those who are in crisis, and we are the service provider who responds to Sutter Amador Hospital for 5150 evals and other mental health related needs on a 24/7 basis. Due to the lack of crisis workers providing services after hours, all of our clinical staff are also on call for after hours services. Continued recruitment for extra help crisis counselor positions is always ongoing. We currently have 2 extra help crisis workers that assist with after hours crisis coverage. And there's also ongoing recruitment for the extra help crisis worker positions. Although that has proven unsuccessful, and that negatively impacts our clinical staff and the amount of additional hours they are required to work. Our clinical staff are also required to provide in-person walk-in crisis services during regular business hours, as well as phone support. Our clinical and psychiatric staff provide mental health services at the Amador County Jail as well. Clinical staff provide safety cell evaluations and weekly mental health consults and visits with inmates. Our psychiatrist provides weekly medical services to inmates, either by telehealth or in person. We have been reviewing our data from the past 3 years, and we have found the following. When clinicians leave our workforce, their position remains vacant for an average of 2 months. The majority of clinicians who have left employment with us have worked for the department for 2 years or less. As it currently stands, only 3 out of 6 clinicians have worked for us for over 2 years. Even though at one point the department was able to fund 7 extra help crisis counselor positions, consolidation has occurred for budgetary reasons and due to the fact that the position was extremely difficult to recruit for. More recently, the rest of the extra help crisis counselor positions were consolidated to create a full-time crisis counselor position, and that provides additional crisis support in order to alleviate the amount of on-call hours the regular clinicians are required to cover. And this helps with client cancellations due to other clinicians being pulled away from their schedule due to walk-in crisis and other crisis clients. This position was filled for about 7 months, and then the staff who was hired for that position ended up applying for an open clinician position. So now our other crisis coordinator position is now vacant, and we're actively recruiting. 60% of our turnover is in the clinician or crisis positions. However, we also employ 2 full-time PSCs, personal services coordinators, and 1 extra help PSC position. When a PSC leaves their position, it remains vacant for an average of 2.5 months. Currently, we have 2 full-time PSCs. However, 1 was only recently filled earlier this year, and it took over 6 months to hire for that position. The extra help PSC is currently vacant, and the average length of employment for the case manager or PSC position is about 2 years, with the exception of 1 who stayed for 4. More recently, we have created 2 additional full-time PSC positions, and we are actively recruiting for them. And one of the positions will focus on co-occurring mental health and substance use disorders. Another note is that we were also able to retain a medical assistant who decided to leave, but she's coming back extra hire for us as well. We also employ 2 peers, and when those positions have become vacant, they have taken an average of nearly 3 months to fill. Since 2019, we have hired 24 direct service staff, which includes clinicians, crisis counselors, crisis coordinators, extra help crisis counselors, PSCs, and peers. Our staff is strategically hired, and each position is unique and valuable to the overall system of care. So when 1 staff member leaves the team, it has a significant impact on how the system operates, and that trickles down to the client and the care provided. Current efforts at the state and federal level target workforce recruitment and retention using a variety of methods, such as scholarships, loan repayment, and pipeline programs, all of which are very, very helpful to some degree. But in small rural areas, the current workforce recruitment and retention efforts are not meeting our needs. We have actively tried to pursue other recruitment and retention activities. We participate in HCI's workforce and recruitment efforts through the regional partnerships that are facilitated by CalMesa. Our stakeholders directed us to participate in the loan repayment program, which we have done since the beginning of these efforts. And we had 5 clinicians apply for that program. And as it stands today, 3 are still currently working for our department. 2 left, 1 before they could even sign the contract, and other halfway through. We are also a National Health Services Corps certified site. 1 county employee has received a loan repayment program with a 2-year service commitment. However, our other staff are unable to apply because they're not licensed. So you have to be a licensed, mental health provider, not registered, to meet some of those requirements that these programs offer through the NHSC. The scholarship opportunities are limited and do not include the behavioral health field to the extent that we really need it to for our rural community. We actually have staff right now that want to pursue higher education, and they looked into the scholarships offered through the NHSC, and nothing really applied to what they were trying to do. Using short-term funding that offered more flexibility to meet our local workforce needs, we offered the following. We were able to offer sign-on bonuses earlier this year, and we had 1 new staff member received that bonus, and they are still employed with us. We also were able to offer crisis incentives. So with short-term funding, we offered $500 per month to licensed and registered clinicians if they were on staff and available for a period of 3 months during December 2022, January and February 2023. Between $500 and $1,500 is what our clinicians received, and 7 of those 8 staff members are still with our department. Both the sign-on bonus as well as the crisis incentive was successful thus far at retaining our employees. Both suggestions came directly from feedback that we received from our staff and our stakeholders, which is why we think it worked. This innovations project addresses the problem by creating strategies specific to our county workers and our community. The unique considerations section, starting on page 5 of our proposed plan, outlines the challenges our workforce face. These include crisis work, lack of higher educational opportunities, lack of providers, which creates a higher caseload, low housing stock, impacts on staff morale and workplace culture. The proposed project details several ideas of ways to effectively recruit and retain our local workforce, all of which were developed using local employee feedback, ascertained from exit interviews and focus groups, and our community program planning process. We also used information and research we did on employee programs that exist outside of the mental health system. If approved, we would develop a core innovations team and work with staff by conducting surveys, interviews, and all of the above to determine how to prioritize the ideas and then develop an implementation plan. The implementation plan would then be provided in stages to offer for flexibility so that if one approach is not working as intended or isn't effective, the opportunity to pivot is there. This project is unique and innovative because it addresses the need by directly using staff and community stakeholders as the experts. They get to determine what is pursued in order to incentivize them to stay. This project is going to help us learn how to better support the public behavioral health workforce within rural and remote areas, and then offer up those successes of this project to other counties and communities and other professions. Our community program planning process was used to solicit feedback for this innovations project. In fact, it started with our community program planning process, and that's why we started exploring how we could better retain and recruit for workforce. To be more specific, in our 3-year plan back in 2020, there was an overwhelming response to an open-ended question related to the workforce, lack of providers, and retention of providers. The comments included statements that we need to do more to attract providers. We need to do more to increase our capacity to serve our clients. We need more options for Medi-Cal recipients. And we need to not only address our clients, but the people that are serving those clients, right? That we need to also prioritize the health of our service providers. As a result of the feedback received, we included another question, as a follow-up in our stakeholder process, and asked about strategies to improve behavioral health services. And the question was, what are the top 3 most important strategies to promote the mental health of Amador County residents? Folks had 12 options to choose from, and they were asked to pick their top 3. And recruit and retain high-quality behavioral health staff was highly in the top 3 for the past 3 years. So stakeholders have continued to identify for 3 years now that the recruitment and retention of the behavioral health staff should be prioritized as a top strategy to improve and promote the mental health of Amador County residents. In essence, the community's input is the driver for this innovations proposal. We want to know if the development and implementation of a comprehensive recruitment and retention model will increase retention rates, provide more engagement with staff regarding what their needs are, and how behavioral health can support them in meeting those needs, and increase staff morale to create a positive work environment. One other thing we would like to learn that is not necessarily highlighted in this project proposal is the impact on client care. If the proposed project is approved, the core innovations team will be identifying instruments that will assist us in measuring this newly identified goal. The core innovations team will be creating an evaluation framework with the goal that evaluation will be ongoing throughout the course of the innovations project. The framework will identify data collection instruments, create an administration schedule, and incorporate oversight in order to make sure there's flexibility to change course in the event one approach is not working or needs to be modified. The important part about evaluating innovations projects is also having an open mind. There's always this layer of unintended learning, as we call it, things we learn or come to understand better without directly seeking it out. And when those things come up, we will be incorporating them into our evaluation framework, and that will be reflected in our annual reports to the OAC. The budget for this proposed project plan takes into consideration that all options listed are implemented and that every single behavioral health staff member participates. Although it is very unlikely that all options will be applied to all staff members and that all staff, if eligible to participate, will do so. However, we wanted to provide a full and transparent budget so that the maximum budget amount that may be spent is accounted for. Many of the options that are included in the proposed project focus on retention, which means that a service commitment would be required. And the budget directly ties to the ideas and the unique considerations listed within the project proposal and addresses crisis challenges, career development, higher education costs, pipeline fill, housing and incentives such as stipends for licensing fees, testing, and continuing education. Additionally, an investment in staff morale and wellness is also identified within the budget. The budget tables are located within the plan for reference. And overall, we are requesting $1,995,129 over the next 5 years. All right, so we will open it up for questions.
Thank you, Stephanie. At this time, I would like to invite commissioners to offer comments or ask questions.
I have a question. Currently, when you're doing your exit interviews, what are the clinicians giving as reasons for why they're leaving? And I'm sorry if I missed that.
Melissa, do you want to?
Sure.
Okay.
Sure. Hi, I'm Melissa Cranfield. I'm the Behavioral Health Director here in Amador. And whenever we have a staff member that leaves, our HR department has them complete an exit interview form. But I always meet with folks individually as well. And for our clinicians, the last 3 or 4 that left, the main reasons they were leaving was the crisis work, commuting from another county because we have limited housing in Amador, so the cost of gas and commuting was difficult for folks. But one of the main things that in the last few people that have left is the crisis work and limited compensation. And our standby time for after hours is only $4 per hour, and that's been one thing that current staff and staff that have left have expressed. They would like more for that.
Can we get clarification on the standby salary? Can you repeat that?
Yeah, for the standby. So when our crisis workers or clinicians are on we have a after hours on call schedule, they do get standby pay for the time that they're on call. And currently that's $4 an hour. So that means while they're waiting for a call, they're getting the standby pay. But it also means they can't leave the county. They have to be ready to respond within 1 hour. So if you have folks that commute more than an hour, they have to make sure that they're in a location they can get to the hospital within an hour. And then, so during those hours, the standby hours, they are getting that salary of $4 per hour. Then if they get a call, then it goes into overtime at that point. For our full-time clinicians, for our extra help folks, then it's their regular salary starts at that point.
Other questions?
Madam Chair, you have a couple hands raised.
Thank you, Commissioners.
We have
Gordon.
Robinson and Gordon.
Yeah, Commissioner Gordon. I'm sorry, what was that, Mariani?
Oh, just we have.
Oh, okay, Commissioner Gordon and then Commissioner Robinson, please.
Thank you. I wonder, have you considered working with your 2, I guess, soon to be 1 high school in terms of trying to interest young people in these types of careers, and then potentially supporting them throughout their higher education with a peer specialist or similar types of work in the county, and they might be people, young people who are interested in staying in the county in the future. It wouldn't solve the immediate problem, but down the road you could create a pipeline.
Absolutely. Yeah, we have explored that option to an extent. Part of this proposal would be, expanding that a little bit more. We don't have a community college, as you know, here. We don't have a four-year school here. I think the nearest one is Sacramento is the nearest four-year school, and then we have Folsom Junior College, which is the closest. However, we do have an access point college. We have Amador College Connect, and they serve as an access point to online learning.
Right.
And they have been really great. They have hired a transition specialist who works with the high schools and tries to get them into these programs early on. So we have like 60 dually enrolled high school students right now. And some of them, if they stay, could qualify for a scholarship program that we use, that we have through them to through the MHSA to get their AA, and then hopefully they can move on to a four-year degree.
Excellent. Thank you.
Commissioner Robinson, please.
Thank you. I guess my first question is, can you talk a little bit about your strategy for employee engagement and how you try to drive employee engagement? Because that obviously is something that helps to improve retention.
Yeah, absolutely. I know Melissa will have probably more to add because she supervises pretty much all our clinicians and our crisis team. But just some examples of what I've noticed that's worked and what really helped us develop this project was we started doing staff focus groups and getting that rich feedback and letting them be heard and letting them talk, and in like an environment where it's safe and they're free to express their opinions has been really, really beneficial to just drive programming on my end. And we also try to do other engagement activities, like Melissa will meet with them monthly we have a standing meeting where they can talk about any challenges that are coming up. We also engage we do monthly like food days here and theme days, and we try to just get camaraderie amongst our staff. But Melissa, did you have more to add with the engagement piece?
Yeah, I think at the level of recruitment, one of the things that we found to be the most effective was when we were advertising for our clinical and crisis positions to include that we provide clinical supervision for those that are unlicensed. That seems to be something that is a draw for people. We also utilize the Board of Behavioral Sciences, the list of those that are currently registered and licensed, to send announcements to try to help with recruitment. And that's where we've actually got most of our most recent applicants for crisis, was directly from that outreach for that recruitment. And then in addition to what, Stephanie was sharing in terms of engaging employees, I think, like she said, I supervise most of I supervise the clinicians in the crisis program. We're a small county, so I don't have a clinical program manager, so I have that role as well. So I have a very open door policy. I meet with my staff often. They come to my door with questions often, and I always try to give the opportunity to get feedback from our team as much as we can. I have 2 licensed clinicians that are our most longer term clinicians that have been here for between 10 and 15 years, maybe even a little bit longer. And I've promoted both of those clinicians to a lead position to help with some more ongoing supervision. So the clinical supervision can be done by them as well as myself as needed. And then we also try to do, like Stephanie said, things that are kind of just staff morale related, and to because the work that we do is difficult. We work with people that have hard stories, and we're the carrier of those stories. So trying to do focus on self-care for our staff. In our monthly staff meetings, we have a self-care section that we've added so staff can share with the team what they do for self-care and maybe lead an activity with our team. We have one of our PSCs, one of our case managers is actually a yoga instructor. So once a month we set aside time if staff want to join. She leads a yoga session for staff, and staff have really, we did that first kind of as a pilot to see what the response would be, and staff were saying this was a great way to start my day. I feel so calm, and so they've asked to keep that. So we've kept that going as something, it's something little, but it's something that we thought we'd try because the staff brought it up, and staff seemed to be really positive about it. So there's things like that we try to do as often as we can. It's hard when you're at county government, there's limited things that you can do, but if we can do, holiday gift exchange, or, we do bingo games like online. And so we'll send an email, here's the bingo call, and we have prizes, and all of our bingo is either cultural competence related, or our new one is on our new EHR to help them learn about that, but then also a way for staff to connect. So some little things like that we try to do as well. But any ideas that we get, we want to try to incorporate that, because it's been positive for the staff we have here.
Thank you for sharing those. And also, just kind of tactically, have you tried referral bonuses, like giving bonuses to staff who recommend hires?
No, we have not, but that's a great one, that if we're able to do this project and move forward with this project, that's a great one for our team to look at to see, because I know that other places, because we've lost, and I didn't mention this before, another reason we lost a staff who was here for almost 10 years because she went to go work for Kaiser and she got like a $5,000 hiring bonus. Her friend worked there and got a referral bonus for referring her there. And then I was worried she was going to try to recruit some other folks from here because she would, referring someone, she would get something. So that's a good one. I don't think we have that on our list, but it would definitely be one to add.
Thank you.
Yeah, thank you.
Please, Commissioner Bunch.
I just want to congratulate you guys on everything that you are doing. And we do a lot of really similar things at our clinic, and notice that it's really the small things that can really boost morale. Like we do a Monday mood where everyone meets in the lunchroom for coffee at 12, just to get a good start on the week. I had a specific question about your proposal and the home loan down payment assistance. I know there was a note that San Diego had previously brought that up and it was denied, but that you believe that your proposed housing assistance is different than San Diego County, and I just wanted to see if you could expand on that.
I can start if that's okay, Melissa. So the reason we brought that up and put it into the proposal to begin with was because it was in exit interviews, it was ascertained that people tried to move here and couldn't find housing. To be honest with you, we put that in there as an incentive. However, we're not sure how much that would be utilized. And then honestly, to expand, during our public hearing, there was this suggestion that instead of using funds for down payments and home loan assistance, you would use it more for moving and relocating if necessary, or the idea came up to actually have the county or behavioral health basically rent a space to offer up for people who are doing crisis work or they're on call that night and it doesn't make sense for them to drive an hour home just to turn around and come back, so that they aren't in the office working, they're not stuck in a hotel somewhere, but they can actually like have a space where it's, like the crisis apartment or something, so those are ideas that have been floated around. And to take a few steps back, I'm sorry, this would only be implemented if the staff through our engagement process identified that that's something they utilize or something they need. It was just an idea that came from the exit interviews that we incorporated into the plan.
Commissioner Mitchell, please.
Yes. Stephanie, I am just, I think that your ask is reasonable, but I also think that it's under, I'm just so touched by your, I mean, the $4 threw me off. I mean, you've thrown off my entire thinking today with this. How do we help you sustain a workforce when these are your salaries for, again, we realize you're a small county. Your budget needs to be augmented some way to sustain a viable workforce. I think that that's the bigger issue here, but I'm not really sure how we, can help you long-term, or I don't know if we're addressing the right question with this proposal.
I think to what it comes down to for us, and Melissa and I've had many conversations, is it comes to retention. If you notice in our data, it's not getting people to apply or come to work here, it's getting them to stay. So if we could, like you said, if we could use this innovations project as a way to find out what gets people to stay. If our turnover rate with clinicians and crisis workers and our, all our direct service providers is about 2 to 3 years, can we learn in the next 5 years what we can do to get people to stay here and work and sustain that? And implement in stages so that we know if this is working, keep it. If this isn't working, try something else. And actually have the flexibility to do that. That's the help that we need. Melissa, do you have anything else to add?
No, I think that's really, that was kind of wraps it up of what, the retention is the issue. And I think that, some of the feedback that we have gotten from staff when even though and Stephanie had talked about this in her PowerPoint, we had some crisis funding that we were able to give our crisis staff some small stipends. And yes, it was for 3 months only, and it was $500 each. But the response that we got from staff was that they were so appreciative of that. They were excited about that. And it was something that, even though it was fairly small, it had a big impact. I don't know if that's going to be the thing that keeps someone here for multiple years, but if we were able to offer retention bonuses and other monetary things that could help with extending the length of time that people stay, I think it would be beneficial. But
well, let me ask you this. Do you think salaries in your county is a reason for your turnover? And maybe I missed that. Do you think that is an issue?
To a certain degree, I would say yes. We've had, let's see, I've had my quality improvement coordinator and 2 clinicians leave, and one went to Kaiser, and their salary is much higher than ours, that the county can't compete with that. Another went to Indian Health Center, and as an unlicensed clinician, they were offered a hourly rate that is higher than our licensed clinician level. Same kind of thing. It's, with our pace, our salary scales with the county, and in comparison to some other neighboring counties, our clinicians are paid a little bit higher, but still not as high as a something like Kaiser or a private health center. And I think that is an issue, but then I think also the demands of the work is difficult for folks. And sometimes, you know, they've said, yeah, more money might be worth it. I can go work and not have to do after hours crisis and make more money. So I think it's a combination.
Okay, well, I appreciate your earnestness. Just in my thinking, I feel that long-term, maybe your county should, maybe you should look to augment your budget. I think this may be a short-term solution. We are dealing with the issue of hours, and I mean, we just heard that in the prior presentation, but I think your issue may have something to do also with salaries, which is an uncomfortable space for people to talk about, often women. But there's no harm in saying we need to be paid more. And so you're a small county and you're, again, you're not asking for very much. And often we see that from small counties. And just as a commissioner, my thought is ask for what you need, be bold about it, because your big neighbors have no problem doing that. And so I think that this is an opportunity for you just to give that some thought, because the work is hard and you need to be compensated for what you do. And there is no shame in asking for what you really need. That's my thinking. So thank you.
Thank you, Commissioner Mitchell. Commissioner Brown, did you want to?
Yes, a question and then a comment. The question on the $37,500, that would be offered $2,500 per year of service commitment. Is there a maximum that you have in mind for that? And then on the loan repayment, is there any kind of parameter that you put on that in terms of the amount that could be repaid?
Yes, we would. We would have to develop those for the one that we do with the Cal Mesa with HCI. We do a 2-year service commitment up to $15,000. You get half after the first year, you get the other half after the second. So we have some framework set in stone regarding with the loan repayment, and we would have to work, of course, within our budget for that and see what would benefit staff the most. With regards to the $37,500 with the housing, again, that would probably be a one-time funding, home loan down payment assistance, one time with a service commitment that we would have to still determine. We would at least a year service commitment for that, I would assume. But again, that would be something the core innovations team and the implementation plan would have to lay out.
Yeah, you know, the fundamental question that I asked, and we had another county that came to us with a plan that was actually wanted to use considerably more money towards incentivizing the purchase of a home and equity in a home and so forth. But the problem that I have with that is that we're basically talking about using California taxpayer dollars to provide employees with a benefit that in some cases would be portable to a location outside of California. So in other words, I don't think I'd have a problem if you were paying for a scholarship for a California required training, or if it had some kind of a nexus to the state, even if they left you, if they maybe get hired somewhere else, I think that would be acceptable. But I just have a fundamental problem with the idea that somebody could come in, tell you that they're going to stay for X number of years, get a home loan down payment, or a down payment and a loan, and then maybe a repayment towards that loan for however long they do stay. But my understanding is that these commitments in terms of tying this to a commitment for X number of years is really unenforceable, that the courts have really determined that there's really no way to do that. So I would much rather see some other kind of, use of these funds to, beef up that shift differential, do something where, you're doing something where the service is going to be provided no matter what. There's not a question there. And it's not so much Amador County, because your amount is a relatively small amount that you're asking for, but there's 57 other counties that are going to come to us. And if we set a precedent of, allowing or authorizing the use of these monies for that, I think it creates a problem for us down the road. And it sounds to me as if you maybe have not completely figured out how you would do this, right? I mean, you've got a concept, but not really and my encouragement would be that you would not make that part of the presentation, and would focus those funds, use them to incentivize hiring people, but do it in such a way that that money is invested in the state of California rather than potentially going to leave the state. And the other thing is, frankly, I don't think it's sustainable. It's sustainable for Amador County size, but if every county comes and wants to have, the MHSA fund home ownership or a portion of home ownership for employees in the field, there's not going to be enough money to go around for that. So just my thought.
Commissioner Carnevale, please.
Just briefly, a piece of business advice. I happen to have a startup that works with performance and wellness and corporations, mostly around teaming and relationships. And what I've learned from that deep research is that it's kind of like healthcare, not one size fits all. There are broadly in any given population approximately 6 different mindsets or value systems that employees have. So if you just offer a bunch of things to a bunch of people and you randomly get different uptakes, it's not that doesn't represent success. You have to go to where people are. And for example, one group of the population is going to be very mission driven, and they're going to be incentivized differently than another population that's just going to be transactional. They just want to get their work done and go home, and they might be more excited about the compensation. So you have to parse it out. And if you want to do this experiment, which I think is a great idea, because we don't know the answers. We're trying to solve a problem. If we knew the answers, we'd already be doing it, but you have to do it with enough intelligence if you want to come up with the right answers and ones that are kind of scalable to the rest of the system. Thank you.
Can I add on one more thing too?
Please, Commissioner Brown.
And it's just a thought. There's, I was talking with someone who, from a different county, and we were having the discussion about recruitment for law enforcement personnel. And one of the things that the county does is that they have a kind of a collective wellness/education stipend, I guess, that they give to employees X amount a year, say it's $1,000 or $1,500 or whatever. But that money, you can spend that if you want to do an online course and go to Harvard, but you can also spend it for a gym membership. You can spend it for martial arts classes. You can spend it for a variety of different things that the person has as an incentive. And that money is, not, there's not a chunk of equity that goes along with it that would go in future years. It's spent that year that, as long as that person is in your employ, they're receiving a portion of that money. And I think, maybe if you could retool or think about retooling into something similar to that, or use, an idea that would certainly be a benefit to you in terms of attracting people, putting more money in their pocket, but also at the same time having them do things that would enhance their qualifications as an employee, and perhaps and obviously keep them as well as possible as well.
Okay, so are there any other questions or comments from commissioners at this time?
I'll just comment that I love the idea of focusing on recruitment and retention, and I see the need for it, particularly working in public mental health. But I do struggle with the housing portion of it and kind of reiterate all of the concerns that Commissioner Brown has.
Thank you, Commissioner Bench. Commissioner Mitchell.
Just one last comment. As a possibility, could we ask them to come back maybe in a short period of time and retool this proposal, depending upon, how we feel about it?
So Toby, how would we?
Of course, Commissioner. So in the past, when commissioners have had concerns, you have a couple of options. There were some comments in favor of sort of learning and moving forward. There were some comments around, some hesitation in terms of a particular component of this. One option is to simply move forward with a vote with the proposal you have in front of you. And if that is not successful, to ask the county to take into consideration the comments and bring it back. A vote to oppose doesn't mean the county loses a chance to make modifications and come back. Alternatively, the county could withdraw their proposal and offer to come back with an alternative without going through that process. Typically, counties like to know one way or the other if they would have gotten the votes.
Okay.
With a proposal that actually came out of the community process that they supported before it got to this point. So it's really up to the commission, of course, with consent of the county.
I'd like to point out too that it wouldn't really take necessarily jettisoning the entire amount, because you've got 37,500 that you're talking about splitting between this home down payment, but also as staff relocation costs, which I think are totally legitimate and would be one time and would be, could be kept in the budget as well. I think if there's a willingness to maybe, just extract the home, the loan and the home element and utilize that funding for something in relocation, education, wellness, anything along those lines, it would have my vote and perhaps others, but I think it's, it's up to the county to sort of determine that.
From my understanding, then, we could ask for a vote as is, or we can ask for a change in, and then take the vote how that would stand. We could then ask for a vote with changes to put that 37,500 into relocation, education, or wellness. Stephanie, is that?
Yeah, that's fine with us.
7,500.
Yeah.
Correct.
Yeah. We can remove the loan down, home loan down payment assistance language from that budgetary amount and from the project as a whole. And like you said, reallocate it towards, relocation, education incentives. Yeah.
Correct. So then we will ask for the vote as is, and then we will see how that stands, and then we will go from there. First, however, though, we do still need to engage in public comment. So we will follow that process. So at this time, members of the public may request public comment on agenda item 8 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your requests to comment now. Mariani, are there any public comments? And please raise your hand now as the queue will be closing.
We have one public comment right now from Richard. Richard, please go ahead. Your line's open.
I oppose the home down payment option. That's not what the Mental Health Services Act dollars is for. Thank you.
Thank you, Richard.
That was our last public comment.
Thank you. Now that the public comment has closed, I would entertain a motion that the commission approves the use of the innovation funds for Amador County as presented, for Amador County workforce recruitment and retention strategies. So I would ask for a motion at this time.
I'll move the item.
Second.
Thank you, Commissioner Gordon, and a second from Commissioner Robinson. We have a motion and a second. Are there any additional questions or comments from commissioners? This is as originally as.
Madam Chair, rather than voting this up or down, could we not, would the maker of the motion consider an amendment to approve as submitted with the exception of taking that $225,000 and retooling it, reworking it into the moving expenses, education, and or wellness, and or a wellness program that could be, distributed evenly. I wouldn't even be opposed to doing it with the personnel costs either. But rather than
But that, isn't that assuming that we know what those costs are? If they were to be line item, they may be even more.
well, I think they've already identified a number of other things, and if it was,
Yeah, I'm happy to change my motion to incorporate the assurance that the the Amador staff just gave us that they would remove that.
So the motion on the table then is as, tell me the motion on the table, Commissioner Brown. You're saying to include the changes now.
to amend the motion rather than vote the motion down and then do some kind of a new motion. Could we not just amend the motion?
Amend the motion now.
We know that the county is agreeable to doing it. So just as a procedural thing, and I defer to council, but
Yeah, that was my intent in making the motion in the first place, that with the with the agreement of the county to change the plan as they stated.
It's certainly permissible to do it either way. We can do it as the chair initially proposed, to have a motion and see how that fares the way the motion was presented, or the motion can be amended. And the simplest way, if the mover and the person who seconded the motion is agreeable to that, then the motion is substituted to include the modified language.
Yes, that would be fine.
And fine with me too.
Amador County, are you agreeable with us making that motion as intended by Commissioner Gordon with those changes? Are you agreeable to that?
Yes.
Thank you. So Jeff, let's frame it correctly for the first time as intended with Commissioner Gordon's recommended wording. Commissioner Brown's wording, what was the intent of Commissioner Gordon accepting it that way?
yes. Do you want language from me, or do you want?
Well, a little bit, if you could just clarify the amount, as I've heard two different amounts that would be pulled out from.
There's two amounts. One is 37,500, which was earmarked for a combination of down payment assistance and one-time relocation costs. And then there's a second item of 187,500 allocated towards staff loan repayments. Total is 225,000. I would propose that the amended motion would be that Amador would incorporate that collective $225,000 to be spent on relocation costs, education incentive, wellness programming, or, and I would even add, if they wanted to use it for increased standby pay for crisis coverage, just, you know, as far as it would be, that money would be distributed amongst those categories rather than the first two.
So it's relocation costs, education, and what was the third item?
Wellness
Wellness.
and increased standby pay for crisis coverage.
Number one.
Amador County, is that your understanding and are you in agreement?
Yes.
Thank you.
Standby pay move to, or do we not need to know that? Do we go $5? I mean, I'm just asking.
Yeah, no,
I don't mean to be the dead horse. I really would ask for it. But I'll stick with the vote.
Madam Chair, it's a little difficult to hear.
I'm sorry, Commissioner Robinson, what was that?
I said it's a little difficult to hear. I don't know if the mics are off or maybe it's just my connection.
No, I couldn't hear you there.
Commissioner Chambers, did you have a question?
So I agree with Commissioner Robinson. I think someone was off mic when they were talking.
Okay, I think we're good. There are no other questions. I think Jeff is going to give us the language now as clarified.
So as I understand it, the motion would be to approve Amador County's Workforce Recruitment and Retention Strategies Innovation Project for up to $1,995,129 with a modification of $225,000 moved from the existing category to relocation costs, education, wellness, and standby pay. Did I capture that correctly? That would be the modified motion. And it sounds like Commissioner Gordon has accepted that. Commissioner Robinson provided the second to the initial motion, so we need to know if he is accepting of that change in his second.
Yes, I accept, the maker accepts, and Commissioner Robinson.
Yeah, I accept it too. That sounds good.
Jeff, I would ask you to call the vote now.
Commissioner Bontrager. Commissioner Brown. Commissioner Bunch.
Aye.
Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette. Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal-Weiss. Chair, the motion passes.
Thank you. Congratulations, Amador County.
Thank you. Thank you very much for your time and consideration. We can't wait to come back and tell you what we learned.
We look forward to it. Take good care.
Yeah,
Thanks.
thank you. Thanks so much.
Moving on to agenda item number 9, the commission will consider approval of the request for proposal outlines for advocacy, training, and outreach on behalf of 6 underserved populations. We will now hear from Tom Orrick, Deputy Director, and Lester Robancho, Health Program Specialist. And I would just like to point out that this is the first time Lester will be presenting to the commission. So congratulations, Lester.
Thank you, Chair. He's cool as a cucumber.
Yes, he is. Looking forward to it.
Thank you, Chair Madrigal-Weiss and Commissioners. Yeah, it's great to be joined by Lester, who has been working with all of our commission's advocacy organizations for the past several years and has really become our go-to when it comes to community engagement. So great to present with him. We'd like to share some background about the commission's advocacy contracts. We want to tell you a little bit about the efforts made by our contractor, our advocacy organizations who are currently contracted, share what we've learned in recent listening sessions, and then provide an outline for the next round of funding. This will be 3 years of funding that'll go out through a request for proposal to fund 6 organizations to do this work over the next few years. So you can see our first slide there is a little bit about some of the background of advocacy funding. These contracts exist, and this funding is available to ensure that marginalized populations across the state are represented, that they have a voice when decisions are made at the state and local level about which programs will be funded and the way in which these populations are supported. These populations need approaches that are specifically tailored to their needs, and the organizations that are contracted are able to advocate for those. So in this presentation, we are focusing on 6 of our 9 populations: clients and consumers, diverse racial and ethnic communities, families of clients and consumers, LGBTQ+ populations, parents and caregivers, and veteran populations. So the 9 contracts that we have are scattered a bit just based on when we received authority and funding to provide those to those organizations. But these 6 have been kind of clustered together for quite a while now. We go to the next slide. Before Lester shares about our recent community engagement efforts and presents the outline for the next RFP, we wanted to look back on some of the accomplishments that have happened over the last few years. The commission awarded contracts to 6 statewide organizations. These 6 statewide organizations subcontract with 71 local entities in 43 counties. The organizations conducted 15 annual statewide events over that time. We can go to the next slide. We wanted to share some of the highlights that have happened. The organizations collectively engaged 473 state and local decision makers. They held 124 events. Some of the advocacy representatives were asked to provide keynote addresses. Many of the organizations provided valuable input to the CalAIM project and also the Children and Youth Behavioral Health Initiative. Over the years, we've made changes to these contracts to ensure that the populations are well represented in state and local government as decisions are being made. So for several years, the commission would contract with state level organizations with no requirement to subcontract with local level organizations. So this provided solid representation at the state level, mostly in Sacramento, but lacked a local level focus where decisions about mental health funding are often made. So as a result of that, in 2020, the 2020 contracts included a requirement to subcontract with up to 15 local level organizations in all 5 of California's regions. This effort was successful. As you can see that, there were 71 local organizations who were participated in advocacy. They were strengthened with funding through that process, and they received technical assistance from the statewide advocacy organization. While that was successful, we also recognized that this may have been too much of a good thing in some ways, as it required several staff hours to not only contract with the organizations, but also to monitor the subcontracts at the local level. And this funding is really not designed to monitor subcontracts. We really want the organizations in the field and at the state level to provide advocacy. So for the proposed outline, we are recommending a slightly different approach that we think will meet the goals of advocacy, training and education, and outreach, while providing a bit more flexibility to the contractors in reaching the various regions of the state. So with that, I'll pass it now over to Lester, who will share about our community engagement efforts, what we learned at our listening sessions, and how we propose to structure the next RFP.
Great, thank you, Tom, and good afternoon, Chair and Commissioners. Lester Abancha with Commission staff. I'd like to share a little bit about our community engagement efforts before going over what we are proposing for the next round of advocacy contracts. So in August 2023, Our team conducted a series of virtual listening sessions where we heard from community members, leaders, and advocates from each of the 6 populations. During these listening sessions, we asked questions about critical needs, barriers to services, feedback on leadership, and best strategies for advocacy and engagement. We also released a survey to capture voices from people who were not able to attend the sessions. And finally, we held several group and individual contract meetings with our current partners. From these efforts, commission staff learned valuable information that will be used to inform the RFP. The next round of RFPs, we learned that both state and local level advocacy is needed to effectively elevate the needs of underserved communities, and that a one-size-fits-all approach to local partnerships does not necessarily work for all populations. We also learned that a regional approach, rather than focusing on individual counties, allows the flexibility to address specific needs that don't conform to county boundaries. And finally, we learned that written reports aren't necessarily the best way to capture and communicate the experiences of underserved populations. Instead, statewide reporting should be created in the most accessible and impactful medium for that community. And I think I'd like to mention that one of our current contractors, California Pan-Ethnic Health Network, just released their new podcast called A Right to Heal. So hopefully you can check that out. Which brings me to, I forgot to change the slides. Yeah. Yes. Which brings us to the request for proposal outline, which is included in the meeting packet. One contract will be awarded to a statewide organization for each of the 6 populations. $670,000 will be allocated to the statewide contractor for 3 years, making a total of $2,010,000 per contract. Each statewide organization will be asked to propose a work plan and budget that is designed to address the specific needs of the population. And across the 6 RFPs, all proposers will need to meet the following goals, which include using effective strategies to elevate the behavioral and mental health needs of their population, increase advocacy for each population's rural communities, partner with a minimum of 5 local level entities in each of the 5 mental health regions, conduct training and education, outreach and engagement activities that reach community members, leaders, and providers and other groups, and finally publish an annual report that is in the most impactful media format. Next slide, please. So all eligible bidders must meet these minimum qualifications to submit a proposal. Each bidder must be an established nonprofit organization registered to do business in California with at least 2 years of experience in programs and services related to the mental health needs of the population. And at least 50% of paid staff, board members, or advisory board members must identify as a member of that population. In addition, we have a set of desired qualifications, which include having experience and capacity to subcontract with local and provide technical assistance for local community-based organizations, and have experience evaluating mental health programs. Our tentative timeline will be to release the RFPs to the public over 3 weeks in October in groups of 2, with deadlines occurring in December. And then we aim to issue awards for all 6 populations in, we'll say, early January 2024. All right, next slide, please. Yes, and so that brings us to our motion that the commission approves the proposed outline of the request for proposal for advocacy, training and education, and outreach and engagement, and that the commission authorizes staff to initiate a competitive bid process and enter into contracts with the highest scoring applicants for a total of $12,060,000. And that
Excellent.
concludes our presentation.
Excellent presentation. Thank you, Lester. And Tom. Commissioners, are there any questions or comments? I see Commissioner Brown.
Just very quickly, I was impressed with the thoroughness of the report and the large number of comments that were received from the various groups. I want to thank them for the obvious effort that went into putting this together, staff and the advocacy groups.
Thank you, Commissioner Brown. Any other questions or comments from commissioners? Seeing none in the room and none online. At this time, I would invite members of the public to request to make a public comment on agenda item 9 by clicking the raise hand button on your computer or the app, or if calling in by pushing *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Mariana, are there any public comments? Please raise your hand now as the queue will be closing.
We have 3 in-room comments, and then we have 4 in-room comments and then 5 virtual comments. The first in-room comment we have is from Reginald.
How you doing? I'm Reginald Green. I'm in support of the request for proposal for advocacy. My story is I'm a Navy veteran, served 15 years inside the Navy, 100% disabled, suffer from chronic migraines, headaches, and everything. These art programs have really helped me with depression and other elements. A lot of my elements you can't see, but there's a lot of struggling veterans that need programs like this and support, more support for veterans or whatever. I found Bed Art. That was one of the places that I went to, volunteer with them for 1.5 years, and then they ended up hiring me. So I'm an instructor, a participant, an advocate, and an artist. So, you know, I'm an advocate because I saw that this helps me, and I feel like it help a lot of other veterans because, you know, transition out the military, you don't really have any direction or know where to go, you know, and I think art is very healing. So I appreciate Masaka on supporting us and letting me get the opportunity to share my story, share it with other veterans, so they can get other programs started to help veterans with their traumas and depression and all that. And I feel like it offers a positive outlet for veterans to keep them out of going to drugs and alcohol and stuff. So thank you.
Thank you, Reginald.
Next, we have Tanya.
Good afternoon. My name is Tanya Savis. I'm a 10.5-year Air Force veteran. I'm the Director of Advocacy for the Veterans Art Project. And I want to say I support the release of the advocacy program for the veterans community. As someone with lived experiences with mental health challenges, it has been an honor for me to advocate for those who haven't found their voices. As I tell my story, they hear their story within my story. As a certified peer support specialist and a QPR suicide gatekeeper, it's been a privilege to help empower them to become their own advocates and advocate for their community and within the communities. As I engaged in the pop-ups that we've done throughout California, it has just been such an honor to see the veterans come out of isolation and engage back within the community. Just to see them engage with the arts in the community from that isolation is just priceless. When they tell their stories behind the art, what seems so personal is just so universal within the veteran and the community. So it has been a blessing just to be able to have the Veteran Art Project to help the veterans engage back into the community, to give them back that sense of belonging, which was lost when they left the military. So I just want to take the time to thank the commission for allowing the Veterans Art Project to help represent the veterans community. And I would also like to invite you to our third annual statewide event, which is going to be on the west steps of the state capitol this October the 17th from 10 to 4. So thank you for all you continue to do for the veteran population.
Thank you, Tanya.
Thank you. Next, we have Steve.
Thank you. Thank you very much. I wrote myself some notes and I'd like to read them. Hi, my name is Steve Dilley. I'm the Executive Director of the Veterans Art Project. And we've been very proud to have been able to have this opportunity to serve our veteran population through the arts. And as an artist who finds himself both in the veteran population and the mental health sphere, it's really uplifting to know that there are people that understand the power of the arts to give voice to those who may not realize that they have a voice, or those individuals who may be isolated. The Veterans Art Project supports the release of these updated advocacy contracts. This learning opportunity has been transformative and it helped us to sharpen our focus, to sharpen our language that describes our processes and outcomes associated with art making in community. And like Tonya said, I'd like to invite everyone on the commission and anyone who's listening to come to our pop-up art cafe on October 17th on the west steps of the state capitol. Thank you very much.
Thank you, Steve.
Thank you. Next in the room, we have Lilia.
Hi, my name is Lilia. Good afternoon. I'm speaking on the veteran community population. I'm a recent graduate of Oberlin College. I have a degree in anthropology. My interests have been varied, but orbit around psychoneurology, community, and the arts. I was hired recently by Steve Dilley as a grant writer for VetArt, and what I've seen is that what we have here is one of the most innovative and creative approaches to improving the socio-emotional health of not only the veteran community, but also the mental health of the entire ecosystem and community of California. The passion with which members of VetArt engage with their community and the network that we're building is truly astounding, and it brings me great hope and peace. I'm hoping to continue my education in community, mental health, and the arts, because it is my firm belief that self-expression and connection is what people live for and stay alive for. And this is the kind of support that is passed down through generations. So thank you for your time and support.
Thank you, Lilia. And I'm sorry, I forgot my manners. Reginald, Tanya, Steve, thank you for your service as well.
Thank you. Next, we have our online comments. First, we have Richard. Your line is open.
Hello, I support the proposal for the advocacy projects with all communities serving statewide, especially with the upcoming changes of the Mental Health Services Act that's being dismantled to the Modernization Act. Communities will be affected by this. Current service providers and programs are being funded by counties. If this passes, those programs will be eliminated or gone because of the change. So we need to educate our state elected officials of what they have done or will be done with these negative impact of changes, and those individuals that are served within our communities throughout California. Thank you.
Thank you, Richard.
Next, we have Stacy. Your line is open.
Good afternoon, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I really want to stress these comments that I make should not be considered a criticism of the work of the current staff. The current staff has so much on their plate, and I know they do work so very hard and have little time. But how many staff and how much time are devoted to a project is an indication of how important it is to the Commission. I frankly believe there should be more staff time and staff devoted to developing these projects in the future. I must respectfully disagree that there was a robust stakeholder process because I don't believe that one session per population is enough, at least one single public input session. The one I attended, there were probably no more than 15 or 20 participants, and most of them were connected to the current contract holder. I also believe that there have not been enough reports or presentations to the commission on the current projects. What are the results? Have local policies regarding mental health been changed? Have local organizations developed more meaningful relationships with their local mental health boards, their cultural competence committees, or their MHSA advisory committees? And I did listen, and it did seem like that has been the case, but that information wasn't available until this report now. So again, I just have these questions because the commission always seems to want results from the counties, but I feel that you should ask no less from the projects that you fund. I believe this contract could be it is extremely important to BIPOC communities throughout the state. And I've spoken with many knowledgeable and experienced individuals, and I am very glad because the former rigid parameters of the grants was a puzzle to people. Although again, now you're, instead of counties, you have regions where you're required. So perhaps that is a little less rigid. And it is appreciated that there is a slight difference in the proposed RFP that an additional 1.5% may be used in statewide projects or activities at the state level. Although, just as Richard said, for example, the governor's proposal, it was very difficult. I know one of the leading advocates mentioned that it was very difficult for all of the advocacy groups to convene at the state level, because again, in their contracts, they don't have the money for that. And I know, for example,
Wrap up.
Okay, thank you. Anyway, I just wish there had been more time because this is really important to communities of color, this advocacy grant. Thank you.
Thank you, Stacy.
Next, we have Andrea.
Hi, this is Andrea Crook, and I am here just representing myself today. As a member of the first round of advocacy grants, I just wanted, this work is incredibly important to me, both on a professional and personal level. And my recommendation stands as it did 3 years ago, that we really need a strong advocacy voice at the state level. I can't help but feel or know that the reason it was written this last round was because perhaps maybe folks grew tired of us coming to the commission meetings every week and wanted our efforts to be directed at the local, or every month, excuse me, but wanted our efforts to be directed at the local level, which they were. And we were able to, through our ambassadors, come and report what was happening throughout the state. It really, I feel that there's so much more work that could have been done to Stacy's sentiment at the state level with SB 326 if you had a dedicated statewide advocates. The counties get funded at the local level and may invest in advocacy, as many of them do, not all of them. But if you had a strong state advocates presence, I think that we could make much more meaningful strides in this work. We need advocates at every level. I would also love to see the commission staff create positions for individuals with lived experience to help inform the work of the commission. Advocates are not only necessary in our just coming to report out themes of what we're seeing, but they're also important to be embedded within our systems, embedded within our research and evaluation programs, embedded within our quality improvement teams. Truly, this work, I believe in the philosophy, nothing about us without us. And I just really, I really hope to see someday an investment in statewide advocacy and support from our state leaders. When we tell you, we're seeing counties that are not meeting with community, that are not designing their programs through the lens of the clients and the family members' voice, to please hear us and help us so that together we can have a system that really fosters a recovery. And that's, the end goal for all. So I thank you for the opportunity to speak.
Thank you, Andrea.
Next, we have Melissa. Your line's open.
Thank you. Excuse me, I'm a little under the weather. Good afternoon, commissioners. My name is Melissa Hanna, and I work for United Parents. We're a grassroots community-based organization representing parents and caregivers. As a result of this funding, and most importantly from the support of the MHSOAC staff, Lester and Tom, we as a small community-based organization went from advocating locally to advocating statewide. We've been able to emphasize the importance of peer parent partner services statewide. We've been able to co-empower and build confidence in thousands of parents and caregivers to find strength in their voice and their story. We've been able to employ some of the parents we've served. We thank the MHSOAC for providing this funding for CBOs like ours, and thank Lester and Tom for your continued support. Thank you.
Thank you, Melissa.
And then we have our last public comment. Elizabeth, your line is open.
Thank you. I actually have more, it's kind of like a question, but I realize you guys aren't allowed to answer the question, so I guess I'll make it as a kind of suggestion. I'm a little bit unclear how this new RFP shifts other than not contracting with the local organizations on the regional level. And I'm in Ventura County, and I just know that our county is extremely distinct from other people in the region. So as you're negotiating the contracts, I guess maybe some of that details of what it looks like for these regional partnerships, how that's going to play out. Because it seems like that not pulling out those contracts with entities and the multimedia thing seem to be some of the bigger changes. Just kind of look at how these are changing. And I guess I feel slightly differently, and I'm just going to kind of comment on Ms. Cook's comments. I think the local level is crucial because it's not just the OAC community planning process, it's being part of the advisory boards, or it's now going to become behavioral health advisory boards, right? So I've been advocating for a very long time that we really strengthen and gather information, because so much gets passed through those advisory boards, that I'm just really glad that given all of the uncertainty about what the details of things that are being happening, that the OAC has still made a commitment to funding these stakeholder contracts. So thank you.
Thank you, Elizabeth. Now that public comment has closed, I would entertain a motion that the commission approves the proposed outline of the request for proposal for advocacy, training, and education, and outreach and engagement, and that the commission authorizes staff to initiate a competitive bid process and enter into contracts with the highest scoring applicants for the total of $12,060,000. Thank you, Commissioner Mitchell, and second by Commissioner Danovich. We have a motion and a second to approve the motion. Are there any additional questions or comments from commissioners? Seeing no more comments, from commissioners? We're going to take just one moment. Just one moment, we might have lost connection with one of our commissioners, so we're just trying to get them back on. Thank you for your patience. We're just waiting. One of our commissioners got dropped and we are picking her back up. And as soon as she comes back on, we will have Jeff take roll. Carnivale, would you rather swim in a pool with sharks or piranhas? No.
How about both?
We swim fast.
Just for fun.
Just for fun. That's right. Okay. Mhm. Yep. All right, here we go.
Madam Chair, would you like me to call the roll?
Yes,
now?
please, Jeff. Thank you.
Commissioner Bontrager. Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette. Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Excellent. Tom, Lester, excellent job. Thank you so much for being here. Thank you, community members, for your comments. I want to thank everyone for joining us today to continue the work and discussions around mental health. We would especially like to thank members of the public. We value your input and participation. Our next meeting will take place on October 26, 2023 in San Francisco. We look forward to meeting then. Today's meeting is adjourned. Take care, be safe. We'll see you next time.